Because where it was being subsidized before, where it's no longer being subsidized, they will now have to pay those premiums. Where before their premiums were let down because the government was subsidizing that for them.
So the subsidies that the government was paying to insurance companies has gone away.
That's my understanding. I'm not an expert on that.
But the prices for premium remained, let's say, the same. I don't know if that's the case or not. But because someone else, i.e. the government's not paying the premium, hence it comes down to us to pay the premium. Is that a fair statement?
That's correct. Now the citizen, the Alabama citizen that was on the marketplace before would have owed a premium under, or normally could have been paying it already. The federal government came in, paid that for them. I believe there might have been a sliding scale. It's not my expert, but several of them didn't have to pay it anymore. So when that goes away, they're back to paying it. Now, as to whether or not they're paying what they would have been paying before that happened, because that subsidy's been in place for a while, I can't speak to, but I would suspect it probably had gone up a little, just knowing how healthcare in general works throughout the country. So yes, that's affecting Alabamians and every other state. It's not, Alabama is not alone in any of this. And one of the things too, when you hear me talk about healthcare inflation, we're referencing that services cost is just going up. It's costing more to do business. Services are going up. If we see utilization go down, you can still in some of those spots see that the cost is still up. Even though utilization is down, that means the service and the cost of that has gone up as well.
Is that partly because of the cost of personnel, salaries?
You know, I haven't seen anything in the studies of that, but it is tied directly like inflation in general. You talk about healthcare inflation, and we all know inflation, right? I mean,
Okay.
if anybody's going to the grocery store.
Utilization and inflation and subsidies. Is that a fair statement?
That's fair, yes.
All
Yes,
right.
sir. That's the general.
Question, go ahead. Senator.
Mr. Chairman, thank you. I want to follow up on that. You're talking about health care costs going up. Do you have any idea of the breakdown of the health care dollar? Are hospital costs going up, drug costs going up, physician costs going up? How does that break out?
In relation to SEIB, we could show you from a year over year how much hospital costs has gone up, outpatient facilities gone up, all those. I don't have it here today, but we could provide that if you'd like to see it. I'd be welcome to come meet with you and discuss some of it.
I would like to see that. I think some segments of the healthcare dollar have gone up way out of proportion to other segments of the healthcare dollar.
Could very
Mr.
well be
Chairman.
true. I'm not going to argue against that.
Thank you.
Senator, go ahead.
Thank you. I was just going to ask, it does appear that there is a presentation in front of us. We do have a printout of a presentation from SEIB. Are we going to hear that presentation?
I really would like for you to hear it.
Well, we may, but I want to make sure that we get questions here. I think there's a lot of questions that the body has that we don't understand. We got one over here. Go ahead.
So on the utilization, my question is very ignorant, so I apologize.
No, there are no ignorant questions.
Yeah, it kind of dovetails a little bit into what Dr. Stutz was saying. With these rates going up, does that mean that the dollars amount that are going to the physicians, let's say specifically, are they getting more for a procedure now than they did 2 years ago?
Could be.
Straight to the
procedures. That's
providers?
generally. Oh, excuse me.
That's okay.
Yeah.
Just straight to the providers. I
No.
know facilities, but I'm curious about nurse practitioners, physicians, chiropractors. Those if their reimbursement rates are higher today than they were 2 years ago.
Most likely, possibly, yeah, absolutely. That could bear it. That's when we talk about even if utilization stays the same. I've said it for years when I stood up here. You're going to see a natural increase just in inflation in general. It's just going to happen, and there are a multitude of moving parts to that. It's not just one thing. And when we talk about healthcare complexity, healthcare is one of the most complex areas that there is. It just is simply that. That's just not saying that it is. I've been in it for 26 and a half years, and there's so many moving parts. It'd be hard for me to answer all the
I know.
questions.
Yeah,
but absolutely, there's costs going up, and when just regular inflation goes up, generally salaries, people move salaries up at certain places. So yes, it would logically follow that that's probably an element of it.
Well, for me, it's the end provider has some significance. Especially we talk about our rural healthcare folks that if the providers' rates do not increase in a way that they can keep up with inflation, not facilities, not surgical facilities, but the provider of the service, then I know that they will continue to lose them. And I was trying to justify in my mind the rates increasing, making it to the end provider is what I'm trying to get to. And I don't know if we're there. I don't know if the rates are really keeping up. And so I know Dr. Stutz probably knows more about that than I do, but that's why I was asking that question.
Yeah, it's a good question.
Thank you.
It wasn't a stupid question.
Go ahead.
Thank you, sir. Question in reading, and it's your sheet that I'm.
Oh, you're already looking at it. I'd love to get
I was
into that
looking at it.
and see where we're at.
You had current enrollment as of September of 25, covered lives, 101,649. I was wondering if you've got a little bit of historic data that would help us understand where we have come from and where we are now, as in the relation to, say, 5 years ago, how many state employees were there and how that has progressed up. And then the second part of that question, and then I've got one more, is does an increase in the number of state employees help your process, or does it, how does it affect SEIB costs if, you know, they go up or they go down or whatever?
Correct.
And
On
I
your
got one
first
other
question,
when you get
the
there.
trend of the state employees, we can show that to you if you'd like to see it. But in general, I've really studied that from like 2020 till now, okay? And at 2020, we were at a certain point, roughly hanging around that 32,000, okay? And then COVID hits. There were a lot of state employees that retired out. So I believe the year of 2022 showed a drastic decrease in those employees. That is, to your next question, yes, it affects the funding for SEIB, okay?
So,
Definitely. And then it's starting to inch back up. From right now, I believe from the last numbers I looked at, the state employees have risen about 1% over from maybe last year. It was not enough to put into the state rate trend because you don't want to do that and then those employees not come on board and then you're just sitting there not having enough funding.
I may have misunderstood you, but did you say in 2020 there were like 34,000 covered lives?
No. I would have to look at the
misunderstood then.
exact number. I don't know if I added that to the back of some of my slides. I don't think I did. The number was, ma'am?
It's the second one.
It's this one, the second slide,
The
yes,
first one that
ma'am.
has information.
Right.
I just wondered what that progression is from, say, like you said, 2020 on up to now. in
I'll be able to
looking
get
at
that to you.
The second question is about your medical pharmacy claims history per member per month on number 6 of your slides. It looks like in about 2020, it was about $350 per month, and then now it looks like it's right at $400 a month. And that's like a 1/7 increase, and I understand
I'm
what
sorry,
you're
did you
saying
say you were on slide 6?
Pardon me?
Did you say you were on slide 6?
Yes, ma'am.
Okay.
Slide 6. And I understand, you know, clearly what you're saying about costs going up. It looks like for the last several years, 22, 23, 24, we're about the same, a little dip, then back to about the same level. I was trying to understand what the other factors, and you mentioned some of them earlier, that are causing the increases to occur, but that doesn't seem like over that period of time from 2020 to 2024, roughly about a 5-year period of time, 1/7 increase doesn't seem like a huge increase in relation to what I've seen about the percentage increases of medical costs across the board in our nation. So I just wondered, besides this specific thing, which is actual dollars that went out per employee, what are the other great factors that are causing the increases to be needed?
The great factors that are causing it are the cost in services, utilization, drug cost. There's a lot of moving parts on the difference of costs. For example, your
that would
drug.
all help us understand the process better.
I understand.
It doesn't seem like a huge increase to go from 350 to 400 over a 5-year period of time.
Well, the trend here, this chart on page 6, the reason that I put that in here, and I don't know if this will help or not, was to show over from 2016 to 2024, and you'll see the red box at the bottom that talks about the average annual increase is 3.9%. We worked this with the actuaries. So over that period of time, the increase for medical has been 3.9%, and the prescription drug has been 11.3%. In this state rate that we're asking you to approve today at $11.75, we included a 5.7% on medical and a 10% on the drug through actuarial studies of how that is occurring.
If I might, Representative Mooney, the chairman has a question here. Mr. Chairman.
Mr. Chairman, I was going to say, let's just let Ms. Azar present, and I think you'll hear some very positive things about what they've done internally with SEIB to control costs.
Absolutely. I would really like to
That was my
have
request about 15 minutes ago, Phil.
Yes, thank you. I appreciate
If I
it.
might, though, we have our tight schedule simply won't allow much of this to occur. We have 2 minutes to run through this. And so these presentations will have to be looked at and studied separately and outside this.
Okay, then I would like to
We
take,
are on a very tight schedule here, ladies.
I would like to take my 2 minutes, if you would allow
Certainly.
me to give you
Certainly.
some
Thank you.
very important information, okay? The board in September of this year, this is very important because of the financial situation of SEIB, is agreed and voted to approve a pull from the trust fund, retiree trust fund, for $30.5 million. That money has been taken and has been put into into SEIB's account. That money was taken so that we could survive 2026 and to help us as we move forward. They also approved the benefit changes that went into effect this month. Of the tune of, for 2026, it'll be roughly about 2.7 million, and for 2027, it'll be over 3 million if those estimations come in correctly. So that's very important. The rate of 1175 is different than the one, let's see, it's 1,025. I was about to say 55, I'm sorry. 1,025 you have now to the $18 million. One thing I do want to point to, real quick, and I would like for y'all to be able to go through the slides and look at those, and I'll be willing to meet with anybody that wants to see that, is how the sources are done. You can see where we drew the 30.4 million. This is kind of showing the premium for the employees is in red, the blue is the employer, and then you've got some interest. This shows how the funding source is done for the employer share, the state rate. You got 30% is covered by the general fund, and the remaining in the red is covered by other agencies, federal dollars, grants, fees, and those other things. So a lot of the funding, 70% of the funding, is coming from other sources as well. I think the theme that I would like all of you to know is SEIB has all hands on deck. We have skin in the game. We've increased benefits. We have pulled from the trust fund, and that 1175 rate that you have before you is estimated to require us to have to hit the trust fund again in this year. So that's very important to know. And when you look at these slides, I want you to remember that if you look and at what I have provided, and you think about fiscal year 2028, I can tell you I've run all those numbers, and it is all red. That's if you give us the 1175 today, and then next year you just keep it at 1175, we're in the red. So I just want to make sure that we understand that. That is not from mismanagement, from SEIB. That is what we just talked about a moment ago. That is 100% it. There are so many things that are beyond our control. I just want to show this chart, which is really in line with what we just spoke about, right? So if you'll look, that claims 95.1% of this program is beyond our control for what we just talked about. And I will be happy to sit down and bring some numbers and show how the services and how the fees have gone up and to address that with you. It's very, very difficult for me to give you every single element that is causing the rise in healthcare. But you need to understand two things. One, we are not alone. It is not just an Alabama problem. It is a national problem across all health insurances. That I do know. And two, SEIB is an extremely important retention and recruitment tool for state employees.
Thank you.
And the rate does increase or go down depending on how many we have.
Senator, last question.
You said that if the 1175 rate is held, you would have to hit the trust fund again today. By how much?
Well, our estimations on, let me go to, this one here shows it. I want you to, fiscal 25 actuals are our actuals. You'll see down at the below, transfer from the trust fund shows the 30 million we have already pulled, okay? Fiscal year 2026 projected, look down there at the trust fund, it shows 15 million. We have not pulled that. We don't want to pull that interest off being accrued on that account until absolutely necessary. So that 1175 rate assumes that we have to hit the trust again, okay? In 2026. It does not show hitting the trust again in 2027 because we pulled 30.4 million, may have to pull again, changed benefits that are helping there, and the board still is going to have more difficult decisions on the horizon as well.
Okay.
This is when I say all hands on deck, I mean everyone.
By how much are you projecting?
To the trust fund this time, 15 million. In 2026.
I don't see that on slide 7. Where's the 15 million on slide 7?
You're on slide 10. I'm sorry.
Okay, gotcha. Thank you.
You're welcome.
All right, thank you, Ms. Azar. I appreciate you.
Thank you.
And Stephanie, I apologize. I started out way too aggressive this morning. I apologize for that. That's the 32-ounce Diet Dr. Pepper.
You know I'm used to it. You've been aggressive to me for years.
I asked for that.
And I love it.
Thank you for that. I appreciate it.
You're
And
welcome.
ladies and gentlemen, we're in this together. The agencies and the legislature are in this together. This is the state. We're trying to figure this out. So if we get a little bit of tense, it's the nature of it.
That's true. I understand. And I just want to say one more thing. I'm going to take a little liberty for 1 second and say that we ran what that state rate needed to be all the way up. And this rate only covers our projections for 2027. We didn't come in and ask for more for the all hands on deck approach and the skin in the game. So even though it's asking you for more, we brought it way down to what we needed to close the funding gap. And that's very, very important for you to know.
Thank you for that.
You're
we
welcome.
appreciate that
Thank
very
you.
much. Mr. ALEA. And to the gentleman in the back, yes, sir, if you would, can you get the graphic up on the that we presented, the ALEA General Fund appropriations? There we go.
Yeah.
Yes, sir.
Mr. Chairman, if I might just quickly make a comment. This is very difficult in 15 minutes to try to make these discussions and conversations and make these very important decisions. So I would like an opportunity for Ms. Azar to meet with me, because I did have 4 or 5 other questions regarding that we needed answered before we make these decisions.
I noticed you were very quiet.
Well, I didn't get an opportunity. You kept running over me, but that's usual. But anyway, thank you.
Yes, sir.
I will be happy to set up a meeting with a group of you at the same time if you would like, and we can go through it.
We are 5 minutes over time already. But Mr. ALEA, if you would, look at the chart, and if everyone take a look at that chart. Now, I didn't get this chart until last evening, so I should have had it out earlier, but that's my competence in question, possibly. You see three items there. Number one, you see the vertical bar graphs there. That is the actual cash money general fund that's been appropriated. That does not count federal dollars. That does not count middle column dollars. That is simply what's shown basically on the spreadsheet when you get it in the general fund. Am I correct there, Kirk? Correct me whenever I make a misstatement.
It represents total general fund appropriations. So in any year,
It does count the middle column?
no.
Okay.
It's just general fund, but it does include if you give a SEIB increase that you gave them money for, or COLA, or any other thing, it's included in that number because it's baked into their beginning the next year. It does not include conditional or supplemental appropriations that were given to agencies for capital projects or other needs.
Nor does it count ETF monies. If an agency receives money through ETF, it's not showing on these graphs here.
Right, only general fund appropriations. You got two. The bars represent the general fund appropriations to the agency. The blue line represents the growth in that general fund percentage growth in the general fund appropriation. The dashed line represents the percentage growth in the general fund receipts. There's a point.
So the line graphs are percents, but the vertical bar graphs are cash.
Are actual dollars, that's correct.
All right. All right. Good enough, thank you. So my point here is taking a look is we've got these, you see the percentage items. You see that peak there, I think, when was that, 23, 22? That, ladies and gentlemen, is when, prior to that, ALEA was receiving an appropriation out of DOT dollars. And at that point, that's when we stopped doing that. We sent all the DOT money to DOT, and that excess was absorbed into the general fund. That's what that peak was there for. And then the percentage goes from there. So explain that. Now, the point I try to illustrate here is the growth that's occurring, and also the percentage of growth, showing that the percent of growth in the agency is, for the last number of years, exceeds the growth in the general fund. And it seems like we're getting almost to the point of getting close to matching, not quite. But that's kind of what I wanted to illustrate for the body. Anybody have any questions about that?
Mr. Chairman.
Yes, sir.
This is good stuff. This is very helpful.
It was your
Helps us show-
suggestion, if I think.
Well, I wasn't going to say that, but Kurt, can you tell us what the columns are at the bottom? Are 2000? I can't see what those are. If I know what those years are, it would be very helpful.
It's 21 through the governor's recommended, and I think it's important to know that the 26 and 27 receipts figures represent revenue estimates. As you can see, those are flat and a little bit negative. And then the governor's recommended budget for most agencies, you're going to see those numbers basically connect each other because she's level funded all the agencies.
Thank you.
For the most part.
Any other questions on that? My question related to you, if I may, Mr. Director, is we may be headed into some areas when we know that the growth is going to decline further. How prepared is your agency to absorb that non-growth?
We're prepared. We've been working on it for the last couple of years because Director Poole has been talking about this for a couple of years, and we've spoken with you and Chairman Reynolds over the past 2 years to know this is coming. So you'll see when I get to my slides, I'm only asking for one thing, and it'll be real quick. So we've been preparing and looking at this for a couple of years.
Anybody else got any questions on this? Any other questions? No? Mr. Director, go ahead and start with your slide, and please keep it condensed.
I will, if I can. All right. Request for General Fund 27 is 20 sworn employees, $3.5 million. That's all. That's as condensed as I can get.
Thank you.
I was going to go over these other things and thank you for what you did for me last year and give you an update, but I don't have to.
I have one question in regard to that.
Yes, sir.
A couple of years ago, we funded to the tune of $7.2 million for what was a fast
driver's license system.
Yeah, is that right? Has that been implemented?
Yes, sir.
It's completely implemented.
Yes, sir.
But
we're still working on. We have some software upgrades and some additional upgrades to that system. Now we've been into it for 5 going on 6 years, so we're trying to get there with that. And but yes, it's up and going, and we're continuing to make sure it is. And it's great. It works really well. Online services.
I understand all that, but when we put that in, that was supposed to be, or I thought, was a one-time amount to get that stuff going and up and going. But it's still in the budget, even in the one that came across from the governor. That money, that 7.2, is still in your budget. Is that correct?
That's correct. It's in the general fund. It's not earmarked.
So, do you have any particular needs for that now?
Yes, sir. That's what I was saying. In the going into the driver's license and updating the software and maintaining it. That's where we are. We're going into the 6th year of this, and software is dated out, and we're
so the operational cost of FAST equals the purchase price of the FAST.
Well, the purchase price has been over 5 years, $35 million. So, but we're just updating the software with the 7.2.
All right. Any other questions?
Well, if I might say, we are, and I think we discussed this, we are absorbing some operational costs in there related to the capital expansion of the Capitol Police and their enforcement in the downtown area of Montgomery, correct?
Correct.
And that's coming out of that money as well.
And if I might take a note of that's the state providing services to the city without compensation. Is that correct?
Well, it is, if you want to look at it that way. We go down.
I don't know of another way to look at it.
Well, okay.
I'll answer that.
Yeah.
And I think this is something that the Speaker Ledbetter had talked about with the pro tem, and I think everybody agreed. You know, we've got students walking around downtown, going to museums here in Montgomery. We've got members walking throughout the town. And I think it was a good measure to expand that, at least to the downtown area.
Yeah,
and then
it was 2 blocks.
Yeah, and then the other issue was the fact that they often cover our legislative events in this area that are outside of this building, and then we also had the expansion in the staff for the new facility.
That's correct.
Okay.
And I'm not denying that there's not a need. I'm not trying to say that we don't have a need for that, but I am suggesting that there's many, and it's not just Montgomery. There's other cities and counties that rely upon the state for services, of which we provide gratis.
That's correct. And
All
we
right?
have not,
And
we've done that.
exactly, and we're doing that. And my point that I want to get through is that that we may need to look at that as we consider with our growth that may not continue. The cities and counties are experiencing the same thing. So it's not a matter of just being able to do it. The question is, how long can we keep it up, and how are we going to adjust to that? It's going to take a concerted effort. That's all.
That's correct.
Any other questions?
Yes, ma'am.
Thank you. More of a comment. I do want to thank you all for what you do to protect us.
Thank you.
And I would just hope that we would move in the direction of more protection and not less. When we see what's going on nationally right now, we you know, I had a person ask me the other night, my daughter even asked me, are you all looking at protection for yourselves as well? Coleman Madison knows some years ago, actually, you know, I had to end up, it was a whole thing where a lady ran me off the road. And it was about a vote. That's what it was. And I filed suit. We did all of what we needed to do legally to make her pay for that action, but there was nothing at that time to, even as it relates to policy-wide, for someone who tries to hurt or harm us or try to prevent us from doing our job. So I hope that we are moving more in the direction of personal safety as well, because we are here to do the work for the people of the state of Alabama, and we can't do that if someone hurts or harms us. So that's the direction I'm hoping that we're moving in, some additional security.
We are. That's what I was going to talk about on the, of course, the max real quick, and I know we're pushed for time, but it's been really effective since June of '24, and y'all have supported us the last couple of years. We've had over 4,800 traffic stops, 1,200 arrests. We've seized 418 firearms, 85 stolen cars. So it's been really effective here. With the money you gave us last year to purchase the additional equipment, and the employees, we're now trained, and we can replicate what we're doing here in other parts of the state if we need to. So to your point, Senator, if it's needed, we have the tools and equipment in place to go do that from what you gave us last year. Capitol Security, we've added some of that, some additional personnel, 10 from what you gave us last year. Ma'am, to speak to what you said, that gives us more coverage outside the area and marked cars, and so that's why we were able to take in the extra 2 blocks downtown. The body and in-car cameras, we had the body cameras, we got the upgrade. The in-car we did not have. Very effective. You get to see so much more. Chairman Reynolds understands this when you have a full in-car camera as opposed to just what the sworn officer's wearing. So it's been a huge help. Thank you for that. The radios, we had no coverage in certain parts of the state at all until we got those radios that you gave us money for last year. They work really well. They have saved lives. They've allowed our sworn officers to have communications direct. Now we can communicate with local, state, and federal partners. If we have to go and do what we're doing here in Montgomery with the MAX somewhere else, we can put whatever city or county into the feds, into that radio, and work whatever we need to. So it's an interoperability, and works very good, and thank you for that. And that's all I have, pending any questions.
Thank you. I appreciate your time and efforts. We do. Any other questions? If not, we'll move on. Mr. Ham, you around today? I think you're next, aren't you? You're approaching with an entourage, and you look like you're excited. And let's see. I think if everyone would look now on the screen, we've got Department of Corrections, the same type graphic that we have there. Anyone have any questions about that graphic on what it shows or how it shows?
Where's my little?
Now, Kirk, this does not show anything as far as construction monies of that nature, does it? It does not. It doesn't show anything, again, dealing with federal monies or middle column monies, correct? Okay. Any other questions on that? Mr. Ham,
Yes, sir.
you have the floor, sir.
Thank you, Mr. Chairman, committee members. See if it'll, have we got operator error? Okay.
He's swapping discs.
He's swapping.
Yeah,
All
floppy
right.
disk. There you go.
Y'all have, Mr. Fulford's certainly giving y'all budget information, so y'all have it all there. I'm gonna just talk about,
Do you have this presentation online, or can we get a copy of that in some way? Okay,
yeah,
it's
but
all,
y'all
okay.
should have
Thank you.
handouts.
All right, go ahead, sir.
Sorry. So I always start off with our officers. Something, when we came in, staffing was the #1 issue. It's still an issue that we work on every day. But something I wanted to show, this is our first academy class of 2025 there at the Governor's Mansion. Governor Kay Ivey, she has instituted this, I think, in 24, where the week of academy graduation, she invites the trainees to have a little reception there at the mansion. And I think that is a significant indicator of her support for the Department of Corrections and these men and women that do the job every day. So that's a lot of people right there. There's our second class. I don't know why I'm in the picture, but anyway, that's a fairly large class as well. 2025-03. And then 2025-04, that's our last class, and I'll talk about those uniforms in a little bit. We set a record in 2025. We graduated more correctional officers from the Corrections Academy than any time in history, and that was 473. So as y'all get the legislative reports on our staffing, you'll see that we have made significant strides since 2022 in raising our correctional officers' staffing. So that is a accomplishment that I have to give a shout out to the team. We got a great.
This is in compliance with the court order that we're under, is that correct?
Well, Judge Thompson in the Braggs lawsuit has ordered us to hire roughly 2,500 correctional officers above what our staffing was when that order came out. So we're probably still about 1,800 more to go.
But the trend is now moving upward rather than.
Oh, absolutely, absolutely, and I'll talk about that in just a second. But it's something that we have to give kudos to our team that we assembled at Corrections and our recruiting efforts and our retention efforts to get these people to come. It was, the initial bump was back in 2023 when we worked with state personnel, y'all, and the governor's office to give a pay raise to the correctional officers coming in, and that was just bringing them to the national average of a family of 4. So that was all good.
Mr. Chairman, may I ask a question? So,
Questions take precedence over presentation.
thank you. So the 473, what is your current number?
We have 2,300 and I had that number, about 2,300 correctional officers, security staff.
And we are, what is the goal?
According to Judge Thompson's order, we probably need about 1,800 more. Now, I have to look at the exact numbers.
Thank you.
If I might also add, that number is based upon the number and type of correctional facilities we had back in that time frame too.
Yes, sir, and we still have those facilities now. We got another
Yeah, we
one.
do. Most of them, some of them are, well, anyway, yeah.
Yeah, and just real quick on that, our last 5 facilities that were built, Bibb County being the latest in the mid-1990s, The last 5 were all dormitory. They anticipated that inmates would come in, they would be compliant, that they would do what they needed to, take advantage of the programs we offered, and they're all dormitories. So we have a dorm with, anywhere from 200, 300 beds in there. So that inmate population, the last information got from the Sentencing Commission, the inmate population is about 80% violent. So when you start congregating those people together like that, there are issues. But the new facility in Elmore County is going to be 80% sales, so we can manage that population a little bit better. It's safer for the inmates, safer for...
Hey, Mr. Ham, I'm glad you brought that up. With the new facilities hopefully coming online soon, is this going to change the number of required people because of technology and be able to monitor using fewer people but able to monitor more? So have you all looked at the numbers? Is this going to be the same requirement?
Yes, ma'am. We look at technology all the time to help us be more efficient and do our jobs a little bit more efficient, but the courts are not going to look at just technology in supervising inmates. It's not going to totally take the place of a human body having interaction with an inmate. Now, parts of it will help us out. I know everybody's talking about AI. That's a big issue in law enforcement corrections that we're trying to stay on top of. So we know we have limited resources. The Alabama legislature and Governor Ivey have been good to the Department of Corrections over the last several years in trying to give us the resources we need to bring our facilities, personnel up to standard. So we always look at better ways to build a mousetrap. However, custody population, these inside the walls, these are the people we actually have physical custody of, and you can see the upward trend there. Can I say any one thing is causing that? No, it's a multiple. There's no silver bullet fix to Department of Corrections. There's no one thing that puts us in this situation. And that population, that's, hey, DAs are prosecuting, judges are sentencing, and legislatures passing laws. So we have to adapt accordingly. But that is something that, I hope y'all are mindful of.
Yes, ma'am, go ahead.
I want to be kind of also sensitive to the time, but this is a budget hearing. And Director Ham, do you know we're getting, I don't know, everybody here is getting so many emails from, so I'm on what I'm about to ask, from family of inmates who are making every allegation that you can think of about treatment of their family member. Can you just talk with us a little bit about what you all are doing just to make sure that people are, because they're still human beings and they still live under the Constitution of these United States of America, and make sure that these people are protected and treated humanely, even as they have been convicted of, as you said, violent crimes, if I'm asking that correctly.
Yes, ma'am, and I appreciate you bringing that up. We'll kind of sidetrack budget a little bit, but this body passed a law 2 years ago directing us to stand up a constituent service unit. In which we have. It's still in its infancy, but we have people at all of our major facilities, and we got a way for those family members, emergency contacts to reach out to us and check on their loved ones. We've gotten the response time. It kind of varies, but usually it's about a day and a half that we get back to them. However, these emails, that is a great question, because yesterday, not one of the typical emails we get, but we had a joint prison oversight committee meeting yesterday, and Chairman Chambliss was presiding over that meeting, and one of our DOC staff was talking about the programs, because we get bashed about not having any programs. Well, we were presenting on all the programs, all the opportunities we give our inmates in our care. Sitting there, I received an email from somebody listening or in the audience basically said that the DOC official giving the report was lying. There are no programs. There's only 3 drug treatment programs, and the Ingram staff, teachers, do not show up. Well, they sent it just to the committee and myself, in which Senator Chambliss, he knows better than that because he's on the Ingram Foundation board. He's in and out of those facilities all the time. We didn't stage those pictures yesterday. We don't stage stuff for Senator Chambliss to come in. We train about 3,000 inmates are in class right now learning a high demand skilled trade. That is our partnership with the community college system. But going back to these chain emails, we have emergency contacts for inmates. They can put down 3 folks. That's who we deal with. We can't deal with somebody in California that is cutting and pasting, talking about a man-sized hole at Bibb Correctional Facility in Dorm A. That is just blatantly false. But they just continue and inundate y'all's emails, my emails, and what, 200 other people? Because that's usually what they say. They don't even know these people. The hole they're talking about at Bibb, yes, we're aware of it. It's where a intercom box was. So if you can fit through there, good. But that is her. Miss Laura Hall right here, she has started responding that we have a system in place, the constituent services. So if you want to find out about your loved one and it's urgent and emergency, that's the way to do it. Don't send an email at 2 o'clock in the morning, wanting us to respond to it if it's an emergency. If it's an emergency, contact the facility or the central office, and we will certainly check on that because we have issues, never hid from them, but vast majority of those emails are totally false. We do check on them, every single one of them. And occasionally we do find something. But that's my 2 cents, and I appreciate you bringing that question up.
Senator Stutz has a question. Have Senator Stutz?
Oh, go ahead.
Let me just respond to that, since I'm chairman of the Joint Prison Oversight Committee. These emails, we do check into them, and I will say that by and large, a lot of them are false. But when we do check into them, there are times where they're accurate.
Absolutely.
And the commissioner and other staff members are straightforward with me, and so I'm not saying don't send the emails in, because we do check them and we do find problems that way, but by and large, most of them are fabricated or an inmate giving false information to their family. But we do go through the process. We do check all that out and do our best to prevent things before they occur.
Absolutely. And just one other thing. We work hard every day to improve things. We still have a ways to go, but all these people, I mean, they're Captain Obvious, pointing out issues, haven't had anyone step forward and give us suggestions to, hey, have y'all tried this to help out? Now, some sides will just move the inmate. That's a simple statement, but that is a very complex issue of moving an inmate, because we might have to move 10 inmates to move 1. So anyway, thank y'all. I certainly appreciate it, Mr. Chairman. Y'all have my request in there, and it's an increase. Y'all have given supplemental appropriations over the years. If we hit a certain staffing number, we could get it. Well, we've hit that staffing number, and I certainly appreciate y'all appropriating that, and we will use it as judicious and wisely as we can.
Those were conditional. Now, we have a question here for Senator.
All right.
Thank you very much. I'll be very brief. Looking at your custody population graph,
Yes.
do you have any information about a graph maybe that all shows the pardon and parole rate and the recidivism rate? I mean, if we want to reduce that population, reducing repeat customers and getting the people out that need to be out, would make a huge difference. So I'd like to know about comparing those two rates along with the increase in population rate.
Senator, I appreciate that question. And most time when I deal with my counterparts in other states, they can have that information. But in Alabama, Pardons and Parole is a different state agency. So now we can try working with them and get that information to you, or you can ask Director Ward, you know, about the parole rate and recidivism rate. But we'll see if we can't get that information.
I mean, those two graphs overlaying each other would be.
That would be, that would paint a good picture for y'all.
Yeah.
Absolutely a good picture for y'all.
Yeah. All right. Thank you.
Thank y'all. Appreciate it.
Any other questions? Yeah, all right.
Thank you, Senator.
Asking the chair, and he can't answer. Does Pardons and Parole and Department of Parole and Corrections work together? Because this is an example.
Yes, ma'am.
Oh, it's a holistic type of thing that we are trying to work together, and all of this ties, you know, it's the same population. So everybody should be concerned about the numbers that Senator Coleman asked about, as far as, I mean, Senator
Stutz. Stutz.
They don't even look alike. That he asked about, it makes Alabama as a system as a whole look good. And so I know that in the past, there has not been the quite cooperation that I would like to see. So what right now is the status?
We do work together. I mean, we provide all of our information on an inmate to Bureau of Pardons and Parole on a daily basis. So they have that information when someone comes up on their parole docket, that they will have everything the Alabama Department of Corrections has. All that, you know, when the inmate came in, sentence, any disciplinaries they've had, how they've acted in prison, all the courses they've taken, you know.
So you all able to share this information?
Yes, ma'am.
Okay.
If I might, Senator,
and
if I might, that issue of the separate agencies, that's well within our purview. We have the power to do something about that if we choose. Whether, all right, that's certainly, if all the other states do something one way, we're doing it different. We need to have a good reason for that, and particularly if we find that there's the communication is an issue, maybe we need to address that.
And we have. It was, y'all passed a resolution several years. We had the Reentry Commission, now it's the Reentry Task Force. So, you know, we are working not just with Pardons and Parole, it's, you know, the 2-year colleges on there. So we are working together, but that will be a.
I'd like to work with you on that. We can improve.
Ma'am.
All right, ladies and gentlemen, we've got an open time here now. Anybody got any other questions for Department of Corrections? This is our time.
What is the ask? I mean, we've had 3 of these. We've had 3 agencies come up.
Yes.
And I know it's level, but all I've heard is 3.7 million, I think. Is that correct from ALEA?
We've.
If we're truly doing budgets, I want people to understand, in particular our constituents, that we're just not up here rubber stamping things, that we are looking into this. And we're trying to understand this, but we're running at a very fast pace. So thank you, Mr. Chairman.
We're level funded, except for the $40 million that y'all have conditionally appropriated for security staff. So.
And that 40 million was conditionally in the past budget.
Oh.
Yeah. And that's what you're showing and such.
And it's
in
actually in the budget this year. Since we get
that's to cover additional staffing that's required, and it's conditioned upon meeting particular goals. That's in the budgets that we have already.
Thank you. Appreciate you.
Good question. Any other questions going on? Now, again, this is a topic. Director Ham answers questions mostly pretty well.
Mostly. Hey, anything over 50%.
All right, if no other questions, thank you. Oh.
wanted to point.
Yes, public health.
So here's another chart that we've been working on. I think it's important to know that from this point going forward, a lot of the changes in these general fund appropriation amounts and percentage growths are driven by things that are completely out of your control. They're driven by things that are going on in Washington and changes that were made in Washington that you have to adjust to in your budgeting down here. The big growth in public health beginning in '24 is related to CHIP. And then how you maintain and sustain that going forward eats into what you have ability to do. And I think you've got to be able to try to address that, but I just wanted to point that out. You have several more after this that have a similar situation.
And in fact, while you're there, keep that thing up there. This graph shows especially the percentage of a volatile matter. Can you tell the body what those ups and downs are about?
Yeah. So in 2023, you'll see the percentage growth in appropriation, and actually the dollar figure appropriated to public health went down significantly. What that was that if you remember during COVID, there was an enhanced FMAP rate, which provided additional funds for both CHIP as well as Medicaid. So we didn't need as many state funds, so the appropriation for CHIP went down. Well, what happens when it goes down? It's like a seesaw, it goes right back up. When the FMAP changed back and we had to assume the additional cost, you see the bar went straight up, and it was because we had to pick up the additional cost for that.
So public health is directly affected by FMAP in the Medicaid program.
Public health is directly affected by the cost of CHIP, yes.
Okay, dealing with CHIPs.
Dealing with CHIP, that's right. And other federal changes I'm sure Dr. Harris would be glad to talk to you about.
Okay. CHIPs is funded how? Out of what? How many agencies?
Mostly federal money, to be honest with you. We have to pay our matching percentage.
Which these graphs do not reflect.
Yes, they do. Not the federal dollars.
Not the federal.
They reflect what we have to cover in the general fund appropriation to pay our share of the cost.
Okay.
In addition to the other operating money you give public health from the general fund. So it's the whole thing. Yeah.
So this graph, because there's volatility and effects like that, it may not be as clear as the others, but I still wanted to present it. Does anybody have any questions about this graph for Kirk or I on what it's supposed to be showing? Any questions about it?
Thank you.
I assume the silence is everybody understands it all. All right.
No, but Chairman, I ask one
yes.
question.
Go ahead.
So in in this year where we are, public health growth, okay, up a little bit, but our growth as far as the general fund is still going to be down in 26 and 27 to try to meet the growth. Well, 27, it's kind of come to a point.
The costs are continuing to grow substantially, and I don't see an abatement there. And
we don't have any growth as far as the general fund growth, even though things kind of.
That's exactly what it shows.
Yes. So the last two, the dashed line to the right for 26 and 27 represent revenue estimates, as you can see. If he puts back, well, on any of them, they're flat. They're pretty flat. They're a little negative. So the general fund revenue growth is expected to flatten out and decline. Something may change to turn it the other way, not likely, but based on our best guess right now, it looks like that's the case. There's a bill in to deal with the increased cost of CHIP in a different way, but the increased cost for 2027 is about $19 million. The total cost, if you add the base appropriation plus the increase, is about 94.
So basically, I mean, every year we have this discussion, but it all comes back to the same thing, as I keep saying. I mean, we can't manufacture any money, but we have to, if we're going to try to continue to keep up with, which we're not doing a very good job, we just kind of kick the can down the road. And but the issue is that we don't have the funds. So we're going to have to find an additional source of revenue, expanding the pie. I mean, you can slice it up either way you want, but if you keep trying to give somebody something, somebody else is going to get a smaller part. So
you can only carve that pie up so many ways. And I hate to pile on, but if something happens with that SSUT lawsuit, you're going to have a different pie, and it's going to be a much smaller pie than what you have right now.
And this is going to impact local and county and local governments as well, because the services that we try to provide impacts. Basically, a lot of this is in the community. You look at DHR and even public health. That's in the community. So it's going to be a shift in responsibility, which is incumbent upon everybody in this state. Now, I know we don't want to talk about the big T word, where we get the money, what's the obvious source that we can get it from. We've got to change our mindset about some things, and I'm talking about the big G, gaming.
All right.
He said, I'm here to give information only.
Dr. Harris, where are you? There he is, hiding over yonder. Good morning, sir. Thank you for showing up. Before you start your presentation, I would like for you to explain, and which we've talked about a couple of times, and that is the potential, I'll use that term, position your department may be in come this summer. And the request for a supplemental, I think. Could you tell the body about that?
Yes, sir. Thank you. We've had good conversations about that. If I can just make one explanation about CHIP itself. I think most of you are aware of this, but just to be clear, so CHIP is insurance for children in low-income families in Alabama. It's the income range that's above the Medicaid income range. So these aren't the poorest Alabamians, but they tend to be working families that just don't qualify for insurance or can't afford insurance. And so they're that next range of families. The CHIP operates on a model sort of like Medicaid does, in that it's a state and federal partnership. So we pay a state share to pull down those federal dollars to fund that program, exactly like Medicaid does. We actually have a lower match rate for CHIP. CHIP has traditionally always been lower for whatever reason than Medicaid. So we pay a little less to pull down those dollars. CHIP is important to us because there are a lot of families that just wouldn't have the ability to get health care easily for their kids without it. It's administered in Alabama by Blue Cross. Blue Cross has been great partners with us because they manage that program. They have a really big network. Families have a lot of options in where their children are able to get care, which we really like. But this is not just it's not some government giveaway program. This is a program that has premiums and has cost sharing, and there's deductibles and co-pays, just like people that have their own private insurance. People have skin in the game, and we think it's a really valuable program. Over 100,000 kids have insurance through this program that many of them might not be able to afford otherwise. So we have really appreciated the support that you all give us. It's been supported by you all in all the years I've been here, and it's not always easy for me to come here and ask you for this, but we can't do it without your support, and we're very grateful for that. In order to answer your question, Senator, so we each year come and have a prediction about what we think costs are going to be, and as it turns out, we're kind of making those predictions several months in advance. We're rolling these budgets up, requests back in the fall, so we're a year or more than a year away sometimes from when the next fiscal year starts. There has been a lot of turmoil in how CHIP has been funded over the past 5 or 6 years. I have a slide I can get to if you want to see that, but essentially, as Kirk mentioned, when the pandemic happened, there were a lot of changes that we didn't anticipate about how CHIP was funded. So we came and, I came here in 2019 and talked about budgeting for 2020, and in 2020 talking about budgeting for fiscal 21 and so on. After the pandemic started, there were several things that happened. One is that the FMAP, the state share that we pay, was really low for about 3 years. We typically, the plan was to ramp it up to about 20%. 20% is what we would normally expect to pay for CHIP. When the pandemic happened, it was about, they dropped it to about 5%, 4 or 5%. And it stayed that way and only gradually has finally gotten back up to its normal level. The other thing that happened then is that during the public health emergency, there was a federal rule that any child who went on or any person for that matter, who went on Medicaid remained on Medicaid for the duration of the public health emergency, even if they might not technically be eligible for Medicaid. Once they were eligible once and got on it, they weren't disenrolled. And as you know, at the end of the emergency, Medicaid went through this unwinding process where they found all these people that were no longer on the roll. That affects CHIP a lot because there are a lot of families who maybe make a little bit more money this year and therefore their child is eligible for the CHIP program, but maybe they make a little less next year, therefore their child is going to go over to Medicaid. And we talk about insurance churn, where families that are kind of on that income break may be in our program one year, maybe in Medicaid another year. So that happens every year, that's normal, but every single child during the public health emergency who ended up on Medicaid for that 1 year stayed on Medicaid for 3 years, or 2 or 3 years, or for the length of the emergency. So not only did we have a much lower FMAP, a much lower state share, we also lost a lot of patients. We were down about 25,000 kids from what we would normally have in a given year. So what that allowed us to do was to have carry forward money. We had already been funded through you all for 2020. We'd already had our budget request in and got funded for 21. So actually in 21 and 22 and 23, we had a surplus, and you all agreed to let us use that for state share. And so the amount of money we got from the legislature was not like a normal year. We got really low additional appropriations from the general fund because we still had this carry forward money. So the carry forward money went through fiscal 25. That's when we, got back to, a zero balance, if you will. And so suddenly now we have a really big ask for match. The total match hasn't gone up, in an unexpected way. It's just the amount that we're seeking from you has gone up because we no longer have that carry forward money. So when we were budgeting, for this current year, for fiscal 26, we were kind of rolling those numbers up in the end of, 2024, submitting them in 2025. We asked for a certain amount of money. We still had a little bit of carry forward at that time. We made our best estimate, but in fact, we're short a little bit in this current fiscal year. I say a little bit, it's about $9 or $10 million, which is not a little bit. But we're short about $9 or $10 million for this current fiscal year. We are also here to talk to you about fiscal 27, which you all are asking us to come present on. And so we will talk about how we're going to get to that point as well at some point. But
Dr. Scott, if
yes,
I may,
sir.
you mentioned that 9 or 10 million. That's we don't have anything in a supplemental here. So how are you going to deal with that?
Yes, sir. So we worked really closely with Director Poole's office on that. The ultimate item in the governor's budget was to request a supplemental from the ETF for that. So it's a total of about $19 million. $19 million is the difference between what we got in the general fund last year and then what we think we're going to need in 2027. We think we can, if that is successful, we think we can get through this current year, 2026. Maybe we'll be okay in 27, even with that amount, but it's just not clear entirely what those numbers will look like. So, yes, sir.
Mr. Chairman.
Dr. Harris, your second presentation there is federal grant rescissions. Now, the funding that you're requesting, and I know we've talked a little bit about this last year. I mean, and I think we've been pretty consistent on the legislative side that we would not be able to supplant, what we lose from federal dollars.
Yes.
So some of this ask is doing just that, right? We're asking state dollars to backfill where we've lost federal dollars.
Well, no, sir. So actually, we're asking for state dollars to pull down federal dollars just for the CHIP program. We actually don't have any new additional ask for state dollars for anything outside of CHIP. You know, we have kind of our continuation cost we put in there for raises and retirement and so on. That's a couple $1 million. That's the only additional ask we have from the general fund.
Okay, so everything on this page where you're showing we've lost federal dollars, you're not asking to?
No, sir, I'm not.
Okay.
The purpose of this slide was to kind of walk everybody through 2025 and kind of what happened in public health, but that is not an ask.
Okay.
No, sir.
Very good. And as has been mentioned earlier, we are going to be moving a piece of legislation that's going to take care of that excess need in CHIPS outside the general fund.
Yes, sir.
Yes, sir.
Thank you.
Thank you.
Yes, sir.
All right, continue. What is the ask then? You're level funded?
Yes, sir. If I could ask the audiovisual folks there, if they could get us, please, to slide number 9 that we have there, and I'll try to pull it up for you there. Thank you. So this is actually this is the budget that was submitted from the EBO from the governor's that you can see there. The general fund has about a $2 million increase, which is really what we call our continuation cost. We don't have new initiatives or new programs or anything we're trying to supplant. There are no programs that we're trying to use state dollars for that we were paying for before. On the ETF side, again, it's about half of that are just what we call continuation costs. We're not largely funded through ETF, as you know. We're primarily funded at our agency through the general fund. We do have one additional item, an initiative that the legislature gave us this past session that we're seeking funding for that I can talk about whenever you like. But that's the change from the ETF and the general fund. And then if I could ask you to please go, next slide, please.
Before you go,
yes, sir.
Let's stick on 9 for just a moment.
Yes, sir.
On the top there, you have merit raises, $879,000. Now, that's not the COLA raise that has been suggested, 2%. That's merit raises that come in normally. Is that correct?
Yes, sir. That's correct.
So that's a normal course of business. I won't call it inflation, but it's a means that the state employees get particular raises periodically. Is that correct?
Yes, sir. I mean, if they earn it, they do. Yes, sir. That's right.
Okay. Thank you.
Yes, sir. That's right. Okay for the next slide there? Or, okay, next slide. So this is actually what we submitted for the general fund for fiscal 27, and what we're, I guess, mostly talking about today. But the proposal would be that CHIP be funded at the same amount in fiscal 27 as it was in fiscal 26, as we are in this current year, as you can see there. And then next slide, please. And then the difference, the change we're proposing would be in a ETF supplemental that you see in that second column there. And then there's actually, again, just one single extra initiative that we are proposing to go into the ETF. But, so I'm not sure how much you want me to, if you're ready for that. Yeah, I don't know if you want to hear about the ETF proposal or not, or.
No, I'm going to let others worry about that.
Okay.
So we are where we are on this. Gentlemen, ladies, do y'all have any questions on this? Is everyone clear on matters of where we are? We have a situation where we are potentially going to have a shortfall in this fiscal year that we're in now, come the summer. And we have a potential answer for that, but we don't have an answer. Does that make sense? And also, we're doing a level funding, which means if we have the problem this year, and we have level funding, we'll have the same problem next year. So that's an issue that I think we need to address or at least or face in some way. Now, if I might, Dr. Harris, you have a middle column in the budget in your department. Is that correct?
I'm sorry.
A middle column. Do you know what I mean by that?
I'm sorry, I'm not following.
Well, most people don't. When we passed the budget, not the spreadsheet, but when we pass the budget, we have the general fund budget, and it shows the general fund dollars that's there. What's not shown, and that's the 3.7 billion that we have. What's not shown is the monies in what's called the middle column, and that is in the bill of the budget. And that's where federal monies and other state monies from other sources come in. And those figures, the total, middle and right column, totals not 3.7 billion, but something like 22 billion. I think I'm correct there. So my question is, yeah, the B. So the question becomes is what monies in that middle column, have you looked at that to make a determination of how you can cover these bases along this line?
Yes, sir, absolutely. We lost a significant amount of our middle column, I guess you would say.
Because that's federal money, is that fact?
Yes, sir.
Okay.
I think the shortest answer would be, we obviously can't use federal monies in CHIP to pull down additional federal monies.
Correct. That's illegal.
So it's not. It can't really take.
Minnesota's finding that out, by the way. But
yes, sir. That we are trying to be really good stewards of what we have. The past 4 or 5 years, there was a lot of federal funding coming down, and it was, there were a lot of things that we felt like we were finally able to do. Now that that's, gone away and gone more back to normal, we have to be really careful about where the money goes and what we spend it on. With all federal funding, it kind of gets siloed into what you can and can't do with it. And so the feds fund a lot of programs that are good programs, and we are glad to do them, but we don't always have a discretion to use them where we would like to.
So the middle column money has a number of restrictions depending on its source, whether it's federal money, or other sources from the states. Is that correct?
Yes, sir. That's right. If it's okay.
Do you have any leeway in anything of those in the middle column? Have you looked at that much?
Well, only to the extent that the federal program allows you some leeway. I mean, if I could ask to go to slide number 3 there, it might give you a little better picture kind of our overall revenue stream. So.
Okay, good. That's a good slide. Yes.
Okay.
3.
So every state public health agency in America is mostly federal funded. That's the way, public health has been funded in this country, and we're no different. About 2/3 of all our revenue comes from the federal government, and that generally comes through HHS, mostly from CDC, but we also get money from other federal agencies like Department of Ag, and we get some from DHS. We get several different things. But it's primarily through HHS. So about 2/3 of our money is federal. Also, the orange slice of the pie, the second largest one there, is our clinical revenue that we get from seeing patients, essentially in county health departments. That's mostly Medicaid patients. We get a little bit of Blue Cross or Medicare, but primarily we're seeing Medicaid patients, and that money is mostly federal money as well. So in a normal year, whatever that is, generally, between 10 and 15% of all of our money comes from state money, and that's mostly general fund. But, around 85%, sometimes as much as 90% is going to be federal sources. So we do a lot of really important work with that, but it's the work that the federal sources tell us we can do with that money. We have a number of responsibilities that are very important to Alabamians that we can only pay for with state dollars. And I would ask you to please go to slide number, sorry, I'm a little behind here. Number 7, please. These are the functions that we do that are mandated either in state law or federal law or sometimes federal rule. But these are the things that we have to do. We get, for a handful of these, we get some federal money, but primarily we don't. Primarily, we use state dollars for the largest number of these. Not all of them, but for the largest number of these. So, for example, our environmental services, people that do restaurant inspections, people that make sure your property will perk before you get a septic tank, people that investigate animal bites, the oyster beds in Mobile Bay. All those things are paid for with state dollars. We don't have federal money, for those programs. the work we do to investigate outbreaks. You know, if you have a flu outbreak that closes a school, or you have a daycare with a diarrhea outbreak, those kind of epidemiology works, those are by and large paid for with state dollars as well. So we have a number of things that we can only do with state dollars. They're actually core public health that are really important things for us to do, but we don't have federal sources for most of those.
And if you would go back to your slide 3, where you had that breakdown, I just want to make sure that I understand what we're talking about here.
Yes, sir.
The bulk of the money, the 777, is that million?
Yes, sir. That's
Yeah,
yes,
just
sir.
make sure we got the demographic, yeah.
Yes, sir.
That is directly tied to the 150 million, which is general fund monies, state general fund monies. So if the 150 goes down, the 777 will go down proportionally. Is that correct?
Well, not necessarily. It depends on the source of the
On the
federal money.
particular program and
So with CHIP, for example, yes, sir, because CHIP, we're actually using state dollars to pull down federal dollars.
Okay.
A lot of those federal dollars are just grant programs that our state applies for, and they don't necessarily require state money to pull them.
All right. Are you suggesting that the 223 million, which is the reimbursement from mostly Medicaid and others, that's coming in, but that's federal money coming in from another state source, but those have restrictions also? You don't have any latitude or leeway on those?
No, sir. So actually, no, that's a good question. Actually, that's how we fund county health departments.
Okay.
So county health departments who see patients in their county keep that money there, and that's how they, you know, maintain operations. We don't have other sources. You can see local funding for public health is, you know, 1% or actually probably less than that. There was a time when you know, counties routinely funded county health departments. We still have some counties that are really great partners and are able to support us, but over time, a lot of counties just haven't been able to afford that. So seeing patients is how we maintain all the other services. Because we see Medicaid patients, we can also have, you know, other people in those counties to do the other kind of work that we do.
So the only other funds that you'd have some opportunity or leeway to use would be the small green, I think that's green, 5.5 million, which is the other state, no, not the green, the blue, the 1%.
Yes, sir. So other state
That's
funds.
the 6.7 million there, is that correct?
Yes, sir.
Told you I was colorblind.
The bulk of that is going to be Children's First Trust Fund money.
Yeah.
And so, you know, obviously we take direction from that board, and you all appropriate that to us, and it goes towards specific programs, you know, like child safety seats or like newborn screening program. They're children and anti-smoking things. I know all of you know, but that was originally funded by the Master Tobacco Settlement, you know, 20 years ago or whatever. And so we use that money for those purposes that it was designed for.
All right. Any other questions?
Mr. Chairman.
Yes, sir.
Would it be fair to say if some of the strings were removed from the federal dollars and not necessarily raise the number that we're receiving or lower the number, but cut some of those strings, that we could use that money more wisely in the state of Alabama for what our true needs are? Is that the message we need to be giving back to DC?
Yes, sir. That would be wonderful. You know, the practical application of that are what we think of as block grants. And so block grants give us a lot more leeway in using those. We get some. We have, you know, a couple of smaller grants that are federal grants that allow us to kind of fund what we think we need in our state. We feel like people who are public health folks here in Alabama know what Alabama needs best. And if we had the leeway to do that, it would be really helpful.
Any other questions? Yes, go ahead, Senator.
Dr. Harris, on the local 1%, can you articulate some of the services and things that go into that? I mean, what is it?
Oh, yes, ma'am. So the local funding is primarily funding from cities or counties that, you know, give us money for sometimes for certain things in their programs. You know, what public health does from one county to the next can be a lot different. You know,
Is there a formula that, as far as what they put in or based on population or based on what? How is this calculated as far as what
No, ma'am,
local government's paying?
we go, just like we're having this meeting today, our district administrators go talk to their
hand-in-hand
city
type
councils
thing?
and cities and ask for help. Sometimes they have a program they want us to run. So for example, in the city of Huntsville, we do vector control. We run the mosquito trucks in the city of Huntsville. And so we get some appropriation to do that. We actually don't do that anywhere else in the state. And we used to do it more, but we do it there. Down on towards the coast, we, inspect swimming pools at hotels and motels and so on. The county wants us to do that. We think that's a good thing to do, so we do that. We had an animal shelter we operated for many years in Baldwin County until just recently. So that funding is usually given to us with a purpose by the local officials.
Okay.
But those locals, I don't mean to interrupt, but those locals you mentioned, they pay you for those services, is that correct?
Yes, sir. Well, I mean, sometimes.
Yeah.
Yes, usually, I mean, I think you would.
I'll rest my case.
Yeah, no, I think you would understand. If they give us additional monies, they, have the right to expect what we're going to do with it. So, yes.
The reason I ask is because we just had a meeting, breakfast with the League of Municipalities. Of course, these are all the municipalities throughout the state. And we're talking about partnership because this is services. Why duplicate something? You've got a health department in your county or whatever. Why duplicate a service that somebody's already there? But it needs to be a fairness and equity kind of thing, that this is a health situation that impacts everybody in that city or county. And it might be an opportunity for us to just go back because times are hard for everyone. I stated previously that what happens on the state, and I know when we do local budgeting, we look at, this is just about my city, and let the state handle whatever that is down there. But the truth of the matter is that what happens on the state level impacts local governments. So at a time like this, I think we need to be trying to work together. And then this is a low funding for something that is a common issue that impacts health, is something that impacts everyone. I mean, you talk about drinking water, you're talking about inspection of restaurants and places that people eat or what have you, mosquito spraying. But all of this ties back to public health and things that people expect, but they don't have a clue of who's providing this. And so I think that this is something worth visiting.
Yes, ma'am. Thank you very much for that, Senator. That's exactly what we think. I showed you this orange slice of the pie there. That's largely Medicaid revenue that we're able to pull down, but that's how we see all the people in Alabama who don't have any other place to go. A lot of people don't have insurance. They don't have other providers. We have, unfortunately, many rural counties that have very small numbers of providers. So even if you have insurance, you might not have anybody to get in to see. So
that's why I think local government should be more of a partner, because these are citizens in their county or their city that need health care, and everybody looks toward the health department, but point of no return when we don't have funding. So if everybody put in just a little bit more, maybe we can fill the gaps.
Thank you. I appreciate that.
Any other questions we have? Any other questions? Thank you, Doctor. I appreciate you.
Okay. Yes, sir. Thank you all very much. We appreciate your support very much. Thank you.
You too, sir. All right, next up is Human Resources. Ms. Buckner is here, I'm sure. If I can get the guy to put our, there we go. If y'all notice, this is a little more clear, I think, and follows a better pattern, but I think it shows the same type issue, and that is the advancement of growth and non-growth along that line. Any questions anyone have about the graphic? Ms. Buckner, do you have a question about the graphic?
No, sir, not at this point.
Okay, it's good to see you again.
Good to see you.
And I don't know, we've got 30 minutes, and I'd like to see if, first off, has anyone got any questions for Ms. Buckner to start with? No? Ms. Buckner, we have 30 minutes for you, and I know you got if you don't get through it, I want everyone to know that it's available and to pay attention to it.
We had enough copies for everyone, and I don't intend to go over everything that's in there, but there is some information in there that I thought y'all might like to see. I put child care maps in there because we get a lot of questions about child care maps, and it'll show you how many licensed slots are available in each county in the state. Shows you the total license and then how many are unfilled at this point too. So, and there's a few other things in there. I redid some of the SNAP business from the Big Beautiful Bill, and then I put, I think it was about 4 bullets about child care, because child care was a hot issue about 3 weeks ago. There was something that made everybody think that it was all going to be frozen for every state. So far, our child care is not frozen. However, it's a little tricky to get to now. There's something called Defend the Spend that has been named, and we have to qualify for why we're getting it and go to different sites to get it. So, but we are still receiving child care funding right now. Okay, first up, you will see the ops plan. You'll see our 25 expenditures. I'm not going to go over all of those. Same thing with our ops plan for 26. And then there is a page that shows you our budget request. You can see, you know, what we've received. You can see we were totally honest in what we thought we needed to do. I understand y'all can't fund all that, but I wanted to be real with you as to this is what we were going to do. So on page 4 at the bottom, those were the increases over last year that we were going to do if we got the money to do that. Of course, you all know we run 6 major programs, and then we help do emergency welfare services. That's page 5. Then when you look at SNAP and food assistance, 371,000 households. This is a point in time for 740,000 actually today. I believe we're down to 702,000 individuals, but that represents more than 300,000 children. Heads of households is almost 100,000 now that are seniors over the age of 65. Yes.
Ms. Buckner, if I may, if you would go back to the page 4 where we were, I want to call a couple of attention to everybody there. Look, if you would, on the total budget that's listed there, the 3.2, that's billion. Okay, that's not million. All right, that's billion. Then if you look up to the general fund amount at the top, that's what you'll see on the spreadsheet, at the 238 million. And then you've got the ETF, a couple down there of 146 million. So, and then the federal and local, which is should really be federal there mostly, 2.8. Now that's what's going to be showing up. That's the middle column matters that we brought up and talked about. All right.
The 238 was our request.
I follow you.
Yeah.
I got you. All right.
Mr. Chairman, if I could, so look at this layout here. So did you have any rollover money?
Yes.
And what was that amount?
I'm going to have to ask my accountants if I can. Do y'all have that number? We always have to encumber a good bit of that too, because the way our bills come in, I mean, we're still paying, and we're probably a... You got that number?
That's okay. Continue.
Yeah, and we'll go back to that. Did you have another question?
I did not. No.
Okay.
Sorry to interrupted, but you're on slide 8, were you not?
No, sir, I was not. I'm on 7.
7, okay.
Yes, because there's a lot of talk about SNAP fraud, and a lot of it is misrepresented because of social media and that. The biggest SNAP fraud in this country are those people that are doing it electronically. And I'm happy to say now that we've got a chip card in place. I had told y'all, I think last year we were working on getting that. We've got a chip card in place. I understand there may be some federal legislation coming to require every state to have a chip card, because they've asked us, since we are actually leading the nation on that chip card. And then we have also done something else you'll get some complaints about, but that's just the way it needs to be.
Ms. Buckner, you made the statement, that the greatest fraud is caused are
Electronically.
electronically, and yet you think that the chip card going electronic is the better way to do it?
Yes.
How?
Swiping your card leaves you wide open. And EBT was a total swipe. Now, they can still swipe
So
it,
you're
but we're telling
talking
them
about
not
going to a different card, a digitized chip card rather than the electronic swipe card. Is that what you're talking? Is that where the fraud is?
Well, you can use the chip card to swipe. We do not recommend it because it's easier for somebody to steal your information on a swipe than it is
Okay, so your statement about the fraud had to deal with the type of digital or whatever, because the swiping is the unsafe way and the digitized is the safer way?
It's safer. It's not foolproof, though.
Okay.
But the one thing that we did, when we sent out cards before, they were always open to be used in every state. We're sending them out now, and the client has to allow their card to be used in Georgia. And some people in Phoenix City, they're going to shop in Columbus, Georgia, so they're probably going to turn their card on for Georgia, but it won't be open. What we have been noticing for a year and a half, there was too many expenditures going through New York, Pennsylvania, Massachusetts, and Maine. And we've been talking to the feds for probably close to 2 years now about that. And actually, there was a big federal case, I believe it was in New York a while back. Somebody on the inside at F&S was found guilty of about $60+ million for certifying an illegal machine in New York. But it was obvious to us we don't have that many Alabama clients shopping in those other states. And states have the same problem. They steal the number and then they run it through these illegal machines, whoever it is. I don't know if it's organized crime. Like I said before, we work with the Secret Service on this and the FBI, and they've been working diligently, but it's very hard to track it down and figure out where the money's going. But anyway, on SNAP fraud, in 25, we investigated 870 suspected intentional program violations. Those are fraud claims totaling a little over $3 million. We also did 31 trafficking claims totaling $25,000. SNAP collections totaled was over $7 million. When we collect that money back, the feds allow us to keep a small percentage of it. So we kept about $1.4 million. So the total recovery on our current claims on our system, which is $4,565, that's over a period of time, is almost $9 million. You'll see on that last bullet on page 7. So we've always worked pretty diligently on trying to recoup money and get it back. The next slide, any questions on that? And we do get the cases prosecuted. We work with the DAs. If they don't want to prosecute it, they'll let one of my attorneys prosecute the case. Most of them probably don't get prosecuted because we work out a payback for them. I forget what our threshold is, but it's a couple $1,000s. Feds don't want the case unless it's $1 million, but we believe in getting everybody that's got more than they should get. On the TANF side, which is family assistance, you'll see that probably there's not many cases left anymore. In '96, there was 48,000 people receiving what's people refer to as the welfare check, not to be confused with the SSI check, though. There's over 11,000 children, and the average payment's $312.72. So almost half is relatives receiving the check for a relative's child, mostly grandparents. On the child support side, we serve over 190,000 child support clients. Collections last year were $358 million. That's money distributed through the state. Our paternity establishment rate is 98.75%. The threshold with the feds is 90%, but for the past 17 years, we've been well over that. So that's on a different card other than the EBT card that those benefits are distributed on. Child Care Services Program is for over 43,000 children are served. Subsidies average $513 per child. $256 million was paid out in the state for child care. So when we talk about our budget, state money is really low in comparison to federal money, but I would prefer a state dollar because I can't get to the federal dollars without the state dollars drawing it down. We also license and inspect child care providers. You'll see there's 1,436 licensed centers in the state. We're up, over to the right on page 11. In 2020, that was coming out of COVID, there was 1,274, so we're up 162 centers in the state since then. There's homes, and then there's centers. Then on the exempt facilities, that's those facilities that are attached to a ministry, not necessarily a church, but a ministry. And they have to register with us, but we don't go in and provide oversight. There's some health and safety things they're supposed to be meeting according to the federal law, and we look at that, but we're not in and out those homes at all. And on the maps that I gave you, there is one map that shows you where exempt centers are too in the state. It's on page 14. I just thought you might be interested in seeing that. Then on page 15 are those child care rule changes. There's been a lot in the press about how the administration has changed child care. That first rule was to repeal the mandated cap of family copayments. I believe that cap was 7%, and of course that was something we had to do. We're probably going to change our cap and go up a little bit higher than that now. It was higher before that mandate came in. The second one is to repeal the requirement to use grants or contracts for direct services. We never did that. We got a waiver. We didn't think it was right. That's where you might go into a center and contract for 25 slots. Whether they're filled or not, they get their money for it. But we don't do that in Alabama. The other one was to repeal the requirement to pay providers prospectively. We didn't do that either. That's to pay them before the children actually go that month. We've never done that. We got a waiver for that one. The bottom one is to repeal the requirement to pay child care providers based on a child's enrollment rather than attendance. We do that, and we're planning to continue to do it unless y'all want to pass something saying we can't do it. But if I were a child care provider, I'd probably have to close up shop if you didn't pay me on how many are enrolled. My children are now in their 40s, and I always paid on how they were enrolled because they can't hold the slots for them and have a staff ready for whoever comes in that day. It just doesn't work that way in the child care. They're going to hold a slot for you for every day. They're on such a tight budget, they've got to have the money to hold the slots. Child welfare, we investigate child abuse, neglect, and exploitation. You can see on page 18, we went out on over 52,000. So as y'all get all those complaints about child welfare, just think, that's ever how many you got out of 52,146. So it puts it in a little different perspective there. When you look at our CAN reporter source, you'll see law enforcement calls us the most to report things or work with us. We couldn't do without law enforcement. They're a great partner of ours, and we need them very badly. Then education is the next, and so on. So you can see those numbers. If you want to talk to me about it here or privately, I'd be happy to talk to you about child welfare too. Children in the custody of DHR, on page 20, you'll see that we're moving those children on down. We're trying to get them to permanency. And our workers in the field do a really good job under some very difficult circumstances. Our adoptions are up, not where we'd like for them to be. We want to close that door and get permanency for those children as quick as possible because that makes them more healthy emotionally, and they just do better. Now, on kinships, you'll see that we've really been pushing kinships. We're now up to 262. That's relatives of the children that have taken them in. That is a permanency, too, that is recognized by our federal authorities and the court system is involved too. Court system's involved on every child we've got in foster care. So then if you want to just curious about the demographics of the children in care, that's page 23. You'll notice on the age, birth to 3, 25.95% of our children in foster care are that age. Also look at 14 to 17. That's the next highest number of children in care. And then when you look at the next page, you see the reasons for children entering care. Drugs continues to be a huge problem for us because someone doing drugs cannot safely take care of their child or protect them. So I want to call your attention again to the blue on those bar graphs on 24. That is relinquishments, and that is one of our major problems. Not necessarily because of the numbers out of the total population of foster children come in, but about the situations that those children came out of. Some of it's because they've shot a gun, they tried to murder somebody. We're ending up with those kind of children that the foster care system was never set to take care of. And then we have some that are, the parents won't let them come home because of that, because they feel certain they're dealing drugs out of their house. They can't come home. So that going to make them a dependent child in many courts. I disagree with that, but that's how it's working right now, and it's hurting us.
Commissioner, just a real quick question. If I recall, in both the 25 and 26 budget, you requested and received some amount. I think you requested last year $18 million for at-risk, high-risk foster kids in custody, and that was related to psychiatric and mental health care.
Yes.
And so obviously we're not going to be able to fund that going into this 27 budget. What kind of impacts is that going to be? Have you expended those funds or well on the way in the 26
We're
budget?
well on the way. You know, we were in about a 5-year class action lawsuit. I'm still in it. We've come to a settlement agreement. The judge has not signed off on all of it yet. If we can't keep those things going, and one of the bases was lack of mental health services. If we can't keep all of that going, we will be back in it. I was able to agree to not have a court monitor, but we do have to send reports for 3 years after the judge signs the order to the plaintiffs, and then they will have to file a new action in court for us to be back in court. So that's the scary part about what will happen with that.
Okay, thank you.
Because they're very, very difficult children, and that we're even timed on how many days it takes us to move a child once they fulfill one program or once that program's put them out. And a lot of these programs put them out because they say they're not equipped to handle the child, and I understand that.
Thank you.
Commissioner, I have a question.
Yes.
On the relinquishment, 17 plus, these are the number of children you have in this program.
No, 17-year-olds.
Oh, they're 17.
We're a state that we do 17 to 21. We go up to 21 with foster care. Not all states do, but a lot of states do, and there's talk that at some point Congress will pass something making all states go to 21.
What I'm saying is you don't have any children under the age of 17 that parents have relinquished or what?
Oh, yes.
Yeah, that's what I was trying to determine. What is the age group that you have within this? You may not have those readily available.
I don't think I do, but the most difficult ages on relinquishment is 14 up to 21. Because many times they're not going to go to a foster home because they're scared for the other children in the home or they're scared themselves. I mean, we get children that stab their grandmother. True case. Like I said, we've had 2 that were charged as adults, arrested for attempted murder. True cases. We had one that took a baseball bat and beat up a relative with it. We got that child because family's scared. Then the drugs, then stealing cars, guns.
Are there any facilities or organizations that work with? I know that there are, but most of them are private, and maybe they have private pay insurance. But are there any programs that we can work with where you have this category of children where they could be placed and get the counseling and mental help that they need? Or is this something that we need to be looking at? What are other states doing?
I don't know what they're doing, but based on my number of years and experience that I've been in this, there needs to be a component like a day school or something like that. It needs a DYS type component. I'm not trying to say DYS needs something, but that is what these kids need. And some of these parents are coming and asking for help. Some of them are filing CHINS petitions, and that ends up going away when the parent says, I can't come. But there are a lot of parents that don't want to give DHR custody, and we'd love for them not to, but they can't deal with it, whether it be a mental health issue or a criminal type issue. We have grandmothers that have raised kids, and because they're big and they're gang affiliated often, they're scared of them. They can't do anything. So it would be great if there was some kind of day school type program where they had various components where they could go home and eat dinner every night with their family, because the better, and it needs to start probably at 11 years old or 12 years old. And then you wouldn't see, I don't think, as much juvenile crime as you see. By the time we get to them now and they're charged as an adult, there's not a whole lot to do.
So speaking of DYS, do you all work with them in any way with this category of
we work with them all the time.
Our numbers are dwindling. We are trying to get them again in community programs. These are the kids that have gone through the program and are able to be placed.
After they go through the DYS program, if the parents don't want them back, we take them then too. But you have to understand, DYS gets children because the probation officer has been to the judge. And if that doesn't occur and the judge doesn't order them or find them delinquent, then DYS never gets them.
Oh.
DYS doesn't go out there in the county and look for kids. I mean, there is a system in place. But, you know, in 2007 or 2008, we passed a juvenile bill because we had too many kids at DYS. We had them at DYS for what's called status offenses. You curse the teacher, you spit at somebody. Right. If you were an adult, you wouldn't be charged criminally. That was wrong, right. And we had too many kids there. But now we have overcorrected the problem, in my opinion. I'm sure there's people that would disagree with me, but I stand by what I say.
Yeah, I see what you're saying. Our numbers are dwindling at DYS, but it would seem that the children who fall in this particular category, not talking about the one that's been gone to court and adjudicated, whatever, these are the types of people that we need to be now focusing on in DYS.
They've got to get to DYS first. DYS has some wonderful programs, just like DHR does. But they've got to get to DYS first before DYS can help them. And that's problematic.
Ms. Buckner, if I may,
yeah.
Our time's running short. We got to do two things. Mm-hmm. Number one is, did you get the number on the rollover?
Y'all got the rollover number? 25 million into 26.
25 million into 26. Okay, thank you.
Into 26.
Mm-hmm. The second thing is, we've got to deal with the elephant in the room, and that is error rate.
Sure.
And how that's going to affect and afflict us in the next year or so. I need you to give us some, tell us what's going on. Tell us what our error rate, where we stand, and what we're doing.
Okay, we think our error rate is probably going to be 9%. They haven't put the official numbers out there. So what is in your packets on page 30 is still the 24 information that you had last time. We sent one waiver up there hoping they would approve it to just count the agency errors, but they denied that waiver. We've got another waiver up there asking them on QC to judge us on what the worker had before them at the time, because now the worker will do this and then QC may look at it 6 months later, and that's the information they're going by, and it's an error. I mean, these errors in QC are so meticulous, like North Alabama, we had to close some offices because of the weather. Well, we've got errors because the office was closed. You get an extra holiday that wasn't planned or something, that causes errors. I mean, we're thankful for it, and I don't want anybody to take it away from our staff, but it does cause errors in the SNAP program, because if you have things that are set to go out or approvals set to go out and they don't go out when that's an error on us. Doesn't matter. We don't get a pass because people couldn't get to the office or it was
But they've
dangerous.
they've denied the first waiver, and we're waiting to hear about this waiver.
Yeah, because we believe that would make a big difference too.
What's the
Now, there's some
likelihood of
bills in the
getting
legislature. Sorry.
What's the likelihood of getting that approved?
I don't know. I told a gentleman yesterday, y'all know him probably from Government Accountability.
Okay.
He was in a meeting I was in yesterday, and I asked him why they didn't spend a lot of efforts on trying to get the feds to change some things instead of states trying to deal with every little thing.
And that's my message. I don't think we're going to be able to count on the feds for help. We've got to find a way. And we're in 2024, we're at 8.32, and you suggest that now we're at 9. And what do we have to get below? 6?
Yes.
Okay. So we've got that 3% is a huge step.
Mm-hmm.
How are we going to get there? Or are we going to? And if we don't, that's going to cost us a couple $100 million?
Yes. Yes. And there's some bills that y'all have to consider this time in the legislature that if they pass, you're going to shoot that error rate up, way up. And
Have you talked to any other legislators about that? Do you have those bill numbers?
talked to the bill sponsor yesterday.
Okay.
We've talked for 8 years.
We have a volunteer.
I don't think there's a House sponsor on that one. I'm not sure.
Okay. All right. So anyway, tell us how we're going to do this, please.
Well, I do think, I know you can't count on it, but I've worked a long time. And I do think there may be some wiggle room to get some people to change. Because understand, 10 states have got to pass for 2 years. Most states, a lot of states don't have the funding, just like Alabama doesn't have the funding. Plus, the staff involved, taking the caseloads lower will help on the error rate, should help, if you can get the workers, because it takes more staff. We have a hard time. Our most difficult is child welfare, but we have a hard time on the financial side because you have to come to work. You can't work remotely. We can't keep the numbers and the errors right. We let them work remotely during COVID, and our numbers fell down some. So, like I said, more training. We train all the time, and we're looking at other things that states may be doing, but monthly reporting is not the answer to that at all.
Senator, you have a question?
I do. Thank you, Mr. Chairman. Could you go over that again? You lost me on what actually is an error on the snow days and the office closed. And I mean, is it money paid out that should not have been paid out?
No, it's,
I mean, what exactly is an error?
like when the office, well, if we don't give somebody enough money or their money on time, everything works on timeliness too. And if you miss your days, it could be an error on the state for not getting the money out there. If they have to report certain things, they have a time frame to report certain things. If they don't report them on time and the amount's over, I think, $47, then that's an error too. There's lots of things that can cause errors. If somebody moves out of your house and you don't report it on time or when you're supposed to, or the agency doesn't take action on it, that can be an error too.
I mean, do you have a reasonable amount of time to, like, if somebody moves out of the house, how long do you have to report that?
I need to ask
I'm asking, does it have to be reported in 48 hours or 30 days, or, you know, is it a reasonable?
Well, like I said, when QC goes out there 6 months after the fact, maybe when our worker was working the case, the person was still in the house. But if QC goes out there, then the whole time starts over and it can be an error because they're going 6 months after the fact. That's the information they're using, which is different than the information my workers used. And that's one thing we've got up there as a waiver that we're hoping to convince the feds to change. That would help some too. If they move, change addresses, they got to report all that too. I mean, it's a lot. If you bring grandmama in your house, you got to report that she's been moved in. somebody else gets custody of one of your children, or DHR gets your children, you got to report that they're not there anymore, too.
But Ms. Buckner, there's a responsibility on the recipients to report, right?
Yes, but those are errors. When they make errors,
Exactly.
they're the state's errors. That's what we
What is the
had.
time frame? What is the time frame is that they have to report that to you or whoever?
Let me ask my expert.
Depending on the era, it's going to potentially be by the 10th of the following month.
Depending on the era, it's generally by the 10th of the following month that occurred.
Okay, so, and they understand this, and I know we talked about this the last time. So it's not just like, okay, you got days. You do have a window of opportunity to report it. Yeah, and maybe there's a responsibility on both sides.
But like if you're in rural Alabama and grandmama, she doesn't use a cell phone, and she's dependent on a neighbor to take her to the DHR office so she can report it.
She's got to come into the office to make the
No,
report?
she can call us if she wants to, but a lot of our elderly, people do different things depending on it. Or if the office is closed and she calls us, say we're closed for a weather day, she can't report it now. Yeah, she should have reported it the first day or the second day or the third day, but I don't always do things like that myself. So, I think I've got to this time to report it, and I do, and then something comes up and it doesn't get reported, and it can be an error. If it amounts to, I believe it's $47.
What is the penalty for the recipient if they don't report it?
Brandon?
It potentially would be an overpayment. It would potentially be an overpayment or underpayment on the recipient, depending on what type of thing. Like if you add a member to your household, for instance, the grandma comes in and she has income, and families have situations that happen all the time, that things come in and out. Quality control catches them on 1 month having grandma in the house with her Social Security, and you got a situation where that household could have lost their benefits for that, should have lost their benefits for that month, but maybe grandma moved back out next month, they're eligible again. So it's very complicated for a lot of these recipients to be able to deal with.
But if they don't report it, if they're overpaid, and then you find the error, what happens then? Does the error get corrected, or do they just say, oh, well?
It gets corrected, and we recoup that money from grandma.
But that could have gone on for a couple months, right? So it could have been an error that's several $100s, or it could be an underpayment for several $100s.
It's still an error for us, whether it's under or over.
But this is where local organizations can come in to try to offer workshops and things like that to help people to understand, to say, okay, we're here if there's assistance that you need, that we need to help you in whatever. But all of this is connected, because I still think, as I said, all politics is local. And in this case, we're talking about individual families. When local governments or people in the community, these agencies that are out there to help them, they typically get it when the stuff has hit the fan. Now you've gone on a couple of months, it wasn't reported, and now you find out you get this letter, you got to pay this back, and you don't have it. It becomes a hardship. So I think the more information that we have, and the more that we can involve local governments and agencies that are out there that try to help the people after the fact, let's try to get in front of it to educate them and say, here, we're here, if you get this, if this happens, this is what's going to happen. You're going to lose some money.
They do. We do things like that all the time. We work with the family resource centers, too, that we help support somewhat. Alabama Rise does a wonderful job reporting, as do the food banks in this state. It takes everybody, but everybody does make mistakes and don't send something in on time. And the food assistance program is lined with policies, and we didn't make those policies in Alabama. They're made in Washington. And why it has to be as complicated as it is and not simplified somewhat, I don't understand that. But that's not within our control to deal with. It needs to be changed. There's several things that could be.
Thank you, Mr. Chairman. I'm glad you've kept this on this slide. As you look at the slide that's up, let's take Alabama. 2022, we were at 4.68. 2023, now we're a little over 7. 24, we're at 8.32, and you just told us that you're headed to 9.
Mm-hmm.
Okay. Now let's look at Tennessee. Tennessee's down on the bottom and obviously adjoining state. They are at 19% in 22, 12%, 23, and now at 9.5%. North Carolina, 19%, 972 in 23, and then they're at 10. Have you had any conversations with North Carolina and Tennessee to see what they're doing?
I talked to Tennessee. They usually call us to see what we're doing.
Well, they probably shouldn't be doing this on the error rates.
Well, another thing with QC error rates depends on who your federal QC reviewers are too, because some will come in for, you may have those for 2 years, and then another group comes in and you have them for 2 years, and they don't interpret things the same. They call something an error that was not an error.
So internally, I assume it's all hands on deck tackling this error issue.
Yes, it is.
Okay. So are you doing spot checks monthly, quarterly?
We do spot checks all the time. The supervisors
Okay, so
are supposed to.
what trajectory are we heading in with our spot checks? Is it getting worse or is it getting better?
What would you say, Brandon?
I think we're currently about the same or getting better in certain situations. A lot of it depends on what type of error you're looking at, and our client errors they're going up more, and our agency errors, which are in our control, are actually going down.
So your agency is at 9%, right? And you know that you're going to have this, you estimated it was $200 million impact? Is that correct?
Yes.
So what is your agency now doing to assume that you have a $200 million impact? What adjustments are you making within your agency's budget?
I haven't made any in my agency's budget.
Knowing that you've got a 9% error rate and you're going to be hit with $200 million, you're not making any type of budget adjustments? Is that correct?
Not in the SNAP program. I don't know what I could do. And I'm in a federal class action lawsuit in the child welfare, which takes up a lot of money.
Okay, thank you.
Mm-hmm.
Senator Chambliss.
You may not be able to answer this off the top of your head, but I think there's a real problem with the error rate being used the way it's being used. What we need to be talking about is unrectified errors.
I agree.
I mean, if the error is corrected, and there are going to be errors, we understand all that, and some of these are small amounts, some are big amounts, and I'm all for correct them. So do you have any idea off the top of your head, or can get us later, what percentage of these are unrectified? 5%, 100, not 100, 5, 10, 20, any idea about which one, what percentage is unrectified?
When you're saying unrectified, do you mean not corrected or just unrectified because it's not an agency error?
No, either one, and those are two separate categories. I get that because you can't control whether somebody reports moving and all the stuff that happens out there. There's no way that you can eliminate those errors. That's impossible.
Well, we also monitor probably maybe close to 20 reports coming in every day. We use something called the work number. We use twice a month from Social Security. We have asked FNS for some information that was put out in the press about all states, and we haven't gotten that yet. One of the congressional offices is trying to get it for me, and we haven't gotten it yet. They're having a hard time getting it too. I don't know that it was correct when it was said to start with, but if we know it, we're correcting it right away. You know, we're fixing the errors, but once it's an error, it's an error.
Yeah, and that's my point.
Yes.
So, I mean, certainly there are some that you can't correct for whatever reason over time.
We generally can correct them once we know about them. Okay. I can't think of anything we haven't corrected.
Okay.
We take care of that. But when you're talking about client errors versus agency errors, it's about 50-50. It may, shift 2 or 3 percentage points on that, but pretty much they've been running neck and neck. But as Brendan said, the client errors seem to be going up a little more maybe now than they were. I don't know.
So to correct an answer, and I'll give it up, but to correct an answer, let's say someone moves into the family with income, they got benefits that month, that is found later. So that amount that they received incorrectly is deducted from a future benefit.
They pay it back.
Oh, they actually
usually.
pay it back. Okay. So anyway, so that's corrected over time, and the vast majorities, if not all, of those type errors they're corrected. So
Yes.
that was my question.
They are.
Our time is up, but Ms. Butner, let me, if I might, call attention to a couple of things before we leave this topic. We have admin costs of somewhere around 35 million, I think your slides show.
35 to 40. Mhm.
Okay, but the budget that's come across did not have that amount added to it, did it not?
It's in there. Probably the EBO can explain it better than I can, but there is some money in there to cover it, or Kurt can. Yeah, there's Kurt. It's in there, but it's not like added onto the general fund, right?
Well,
Kurt?
we'll have to push legislation this year to make that adjustment for the administrative costs, because as we know, SNAP is 100% federal dollars, correct?
The benefits are.
Benefits
The
side,
admin
it will
costs have been
increase on the admin
50/50, but
side.
they're changing.
Okay,
And we're going to change that formula to pay for that cost.
interesting. So we got that, but what I'm hearing on the error rate and the threat of $200 million, or whatever it may turn out to be, it appears that the likelihood of making the error rate is slim.
I'm not going to say it's slim. I'm saying if y'all pass that legislation, it's probably slim to none, closer to none.
Even if that legislation has not passed at this point.
Right.
And we've gone from, we're at 832, I think it was, and we're up to approximately 9. And from what you're telling us, there's not a lot of control of making much improvement. And that's where I'm getting from. Whether the bill passes or not at this point is immaterial. It's a matter of what can we do or should we do, or is there anything that can be to prevent running into that $200 million wall. And right now, I think that train's got the light on heading straight for us.
Well, when you look at that slide that Representative Whitt was talking about earlier about the years, you can see
right.
when it was lower, we didn't do anything different necessarily then, except we may have gone in and told supervisors, you know, you better do these reviews a little harder at it or whatever, and we do that off and on. We monitor counties. The real caveat is we've always been graded heavily on timeliness, and that's still out there, but nobody put that in the big, beautiful bill. But it's liable to come up at any point about timeliness too, because that's a big thing with FNS. Right. So we push on that, and we push on lots of all the components of it. Every time the staff turns over and you have to train another one again, though, it's much more difficult to get them to do their errors right. And we're not the employer of choice anymore. We used to be a long time ago, but we're not now.
Thank you for your time.
Sure.
I appreciate you coming in.
Thank y'all.
All right, let's move on. Ms. Boswell, mental health. We got my slide on mental health?
Sir?
No, not you. Back there. There we go.
Yeah.
Okay.
Okay.
Now,
Good
Ms.
morning.
Boswell, if you'll take a look at that, it shows the same type thing that I've been trying to show with the other departments, is that we're in a kind of a warning stage that the growth has got to swap places here. The growth in the department, in the agencies, have got to get back in line with the growth of what, or if we have growth along the line. And we're seeing the beginnings of that. If you look at the top of the blue lines, you can see a level, but the growth is continuing to decline. So any member got any questions about that? Is this helpful at all to anybody? Oh, and I get some mediocre. Yeah, I guess good. All right. I guess Ms. Boswell, have at it.
Thank you, sir.
Now, we'll let you go a little bit, but we're running a little bit late, so we may interrupt with some questions. And again, guys and gals, questions precede override presentation, so feel free to jump in. Go ahead.
Yes, sir, and thank you for the opportunity today, and I'm just extremely grateful for the partnership with you guys over the last few years and the difference we've been able to make for the citizens of Alabama. Today I'm going to do something that's a little bit different. Obviously, since we're in a sort of level funding situation, I'm not necessarily going to talk about the increases in our budget, but rather do a pretty deep dive on the status of our overall budget. So the first slide that you see is our 3 major programs. More often than not, people think of the Department of Mental Health as mental health and substance use. Our largest program is the Developmental Disabilities Program, which is 59% of our budget. The Substance Use Program is 9%, and the Mental Illness Program is 32%. Much of the funding for the Developmental Disabilities Program is federal funding. So out of that $773 million, about $606 million is federal. We do have a fairly complex budget. These are all the different revenue sources within our budget. Obviously, federal funds are a big part of our budget. We do have Special Mental Health Fund as well as General Fund and a small portion of ETF. We do have some other income. We get a little bit of revenue, Medicare and Medicaid revenue at our hospital in Tuscaloosa, our geriatric hospital, Harper Center. So we do have some other income. It really is important to know that as the general fund goes, so does the Special Mental Health Fund. So if the economy's good and things are working like they're supposed to and you guys are doing great economic development, we're good. But the same issues that cause a decrease in the general fund usually also cause a decrease in the Special Mental Health Fund. Another important fact to know about our budget is when there is a decrease in state funds, it impacts the beds in our as our state hospital beds are almost totally funded through state dollars, and our MI residential programs and crisis residential beds are funded primarily through state dollars. And if you're like me, when you go out in the community, the conversation is beds. So through this presentation, you'll hear me sort of talk a lot about beds in the state and what the needs are. And we'll start with the dismantling of the public mental health system in 2010. I do remember proration. That was not fun. And then we'll move to how we're rebuilding the system and then managing the challenge. Where are our risks, where are our flexibilities, and then where are our opportunities? So in 2010, the Department of Mental Health received a $43 million cut in the general fund. And as you can see, that really caused some pretty big instability in our public mental health system. The funding continued on, and really we didn't see an increase until much later, which meant a continued decrease and really tearing down the infrastructure that we had on the mental illness side. So what happened during the last 2010 proration? We lost 725 beds. We lost 725 beds, 525 of those civil commitment beds. 200 of those were the last developmental disabilities beds that we had in our state. So we actually went to 0 beds, inpatient nursing home level of care beds for individuals with developmental disabilities. We did also, it impacted our staffing. So in 2009, we were at 2,925 employees. In 2025, we're at 1,294. So most of our services are now out in the community. So it's our community mental health centers that are hiring staff to run those programs in the community. We did put back some beds after all the closures in 2020. Now we have 204 beds. By 2016, we added 204 beds in the community in the form of crisis residential units operated by our community mental health centers. Those were all civil commitment beds on the mental illness side. Right now, we are at 486 beds in the community. 252 of those run by our community mental health centers, and 234 that are in community hospitals, often our rural hospitals in Alabama. And then we have 285 beds at our state hospitals that are the beds that have a turnover for 771 beds.
Ms. Boswell, we've got some questions starting now.
Sure.
Thank you. I have a question about that. So how many of those beds could be filled if they were available right now? How long a waiting list is there for those beds?
So right now at Bryce Hospital, we probably have a waiting list of about 60 people waiting to get in Bryce Hospital. We have we're at capacity in all of our crisis residential units. There's a little bit of turnover, but generally they're at somewhere between 90 and 95% capacity. And then there are folks in the community waiting that are not on the Bryce wait list. For example, in the Jefferson County area and the larger cities, they're actually waiting in the community for a bed. So the number's pretty large.
Yeah, we could double or triple the number of beds and not use up the whole wait list.
Correct.
Yeah. And
Correct.
so why is it taking so long to get those beds replaced?
Funding. At the end of the day, this year, for example, we had $10 million in the budget to add new civil commitment beds. We added 57 new civil commitment beds last year through a combination of general fund dollars and opioid settlement dollars. So at the end of the day, if the money is available, we have the capacity, our community mental health centers and others have the capacity to stand up the beds. There just has to be the funding available to do that.
I appreciate that in your situation. Out in the community, it's not all funding. In my community, we had a private hospital and that was building commitment beds, and it took 2 years for them to get through the CON process. They had the money. They were willing to build it. They were wanting to build it. And because somebody else objected, it took 2 years for them to get through the process. So I'm just making the point that there are obstacles to getting these beds in place when they're very, very needed in the communities. And I had a bill last year to exempt these commitment beds from the CON process, to try to get them online out in the communities, and that bill didn't go anywhere. So it's not all funding, it's part bureaucratic obstacles. And I just wanted to make that point.
So for our community mental health centers, just so they don't have to go through the CON process, community hospitals do have to go through the CON process. Had a conversation with a mayor this week about a hospital where they're having to go through the CON process to be able to stand up behavioral health beds that folks with insurance or whoever can go into those beds. So keenly aware of how challenging it is for some hospitals to get through that process.
Mr. Chair, go ahead.
Yeah, but it is a significant amount of funding is the issue. I know that we had some additional dollars in both 24 and 25 budgets that we could have spent on one-time bed money, but the operational cost was just unsustainable going forward.
Right.
With $42 million in new dollars just on our 6 crisis centers.
Right.
So that's kind of looking forward. We know that's going to be a challenge.
Right. So the good news is, with the leadership of the governor and your steadfast support, we have began to rebuild the mental health system in 2019. So just wanted to go through some of the many accomplishments based on your first slide and the money that you've given to the Department of Mental Health and what we've done with that money. So for our Alabama Crisis System of Care, the 988 call line has seen over 158,000 contacts since July of 2022. Our 6 crisis centers have evaluated over 28,000 Alabamians. Our mobile crisis teams have served over 10,000 adults and over 1,900 kids in that program. In our school-based mental health program, we have, since 2019, stood up mental health services in 118 school systems in the state. And in 1 year, that program served over 12,500 kids. For substance use treatment services, for the first time since 1970, in 2023, we received an appropriation to increase the substance use residential treatment beds in Alabama. We do have 4 new programs. They're located in DeKalb, Lee, Madison, and Walker counties, and those programs combined have served over 400 individuals. We also have seen a huge impact from the Governor's Opioid Overdose and Addiction Council and the Oversight Commission on Alabama Opioid Settlement Funds. We have seen a decrease in overdose rates from April 2024 to April 2025. We have seen a 30% decrease in overdose rates. In our state, we've given out almost 97,000 Narcan kits since March of 2023.
Ms. Boswell, if I might jump in, we're running a little bit short on time. I'd like to deal a little bit with some of the specific monies we've got.
Okay.
If I remember, well, I'm looking at some numbers here, and again, I'm going to be focusing on the middle column money. And part of that middle column money, well, first off, let me go into the amounts. You've got about a $9 million increase from last year to this year, from 1.12 billion to a 1.313 billion. I think that's right, in your middle column. And a part of that, I know most of that is federal money. We've had that discussion. But a part of that is from one of the bills we passed, which is the public utility license taxes. That's coming directly into that. That's coming directly into the middle column. And I think that when we passed that, that was, correct me if I'm wrong, Kirk, isn't that monies that was already taxed that's being shifted from general fund or something along that line?
No, sir, it's already a tax.
It was already a tax.
Traditionally, the money is split 85% to the Special Mental Health Fund and 15% to the general fund. What you did with a couple of different bills that you passed was basically made the general fund eat all the credits that were given, and the
so this is a tax credit issue.
Special mental health
tax credit issue.
Yes, that's part of the issue.
Okay.
But the revenue source is growing. It's just not. General fund's getting none of it. It's going to the.
So it's a matter that we made the tax credit shift so that that money was coming to the general fund. It's now coming into this middle column money, and it is growing, and the general fund is not.
Yeah, you're getting some, but you're not getting the growth that you would otherwise get.
We may have a talk and get a better clarification how much that money really is, too.
Well, it's pretty significant. I think I looked at the numbers. I think 169 million already this year, and I suggest with this cold weather, that's going to increase. So, I think we've got to begin to look at that, Mr. Chairman.
If it goes by what my power bill yesterday was.
Yeah. I don't know that we may have to have that discussion about where we cap that and divert it back into the general fund based on the conditions we know that we'll see in 28 and 29.
And I guess my point that I'm making here, ladies and gentlemen, is again, taking a focus on what money we're appropriating and where it's coming from and how it's reflecting and such. And because the request that's coming in doesn't take those changes into play. It simply comes in, keeps the ladle keeps going into the same general fund pot, even with those things. So I'm just calling attention to that. We may need to look at some issues along that line. Any, Senator, go ahead.
Thank you, Mr. Chairman. The point I want to make about that, and back to the commitment beds and so forth, is the hidden cost of all that in the communities. The backlog in court, the backlog in jails, the backlog just throughout the community because they have no place else for those patients to go. And so the hidden cost of those lack of beds of being available is huge. So and it's felt throughout the system.
So that's a good segue for me to talk about some of the risk in our budget right now. So I'm actually on slide 23. So one of the risks in our budget right now is a contempt of court order for the Taylor Hardin forensic wait list. So when you talk about individuals being in jail, everyone in jail is not on the same path. Right now, if you look at this map, this is the over 400 people that are waiting in jail on the road to Taylor Hardin. So that'll tell you county by county how many individuals are actually sitting in the county jail waiting to go to Taylor Hardin. Right now, what happens if we're in a contempt of court order in this case? There are lawsuits in 6 other states that are very similar that are in contempt of court. Right now, they're paying fines that range anywhere from $500 to $2,000 a day. We are in mediation in this case, which makes me really unhappy. We're in a consent decree. We've been meeting with the mediator to try and present a plan that will allow us to get to 100 in jails in the next 12 to 18 months. So to do that, we need to fill all of the beds that you guys funded at Taylor Hardin. We started adding patients to those beds in November, and we're adding patients every week. We need to hire forensic navigators to help us divert some of the individuals that really shouldn't be on the path to Taylor Hardin. We need to increase evaluator compensation. We also need to open a 16-bed forensic group home in order to address this issue. So that is one of the biggest risks we have in our budget right now. We did have a really good meeting with the mediator. They were excited about this plan. And so it's actually looking pretty good if we can deliver what we said we were going to deliver. But I will note that we're paying for all of this out of the increase in special mental health fund.
And if I might make a point, correct me if I'm wrong here, Kirk, you're the all-knowing, but yeah. I think we passed into law a bill so that in these cases where there's suits, if there's a settlement that's going on, the agency can only settle if it's within their budgetary limits. Is that correct? So just be caution along that line, especially when we're looking at doing a settlement using some additional funds someplace else.
Yeah, I don't want to go there, really. I'd like for us not to be in even mediation, and that's really our goal right now, is to get us back to quarterly meetings with the judge, simply giving updates, and we're actually pretty close to that. The other big risk area in our budget right now is a $28 million deficit in the developmental disabilities program. We started at a $38 million deficit when we started digging into that program. We reduced that down to $28 million by shutting down some programs that we funded through one-time money. We also reduced the staffing by 22 positions, and we instituted a hiring freeze. And so we brought that number down to $28 million. Our game plan was to be able to replace the one-time money we were using to cover this deficit over about a 4-year time frame. Last year, for the residential rates, you guys appropriated $5 million in 2026 to cover the implementation of those residential rates. That left still a balance of $5 million that we needed in order to cover that increase. We also had an issue with FMAP in this program. That's a $23 million total. We were planning to spread that over 3 years and receive $21 million. We did transfer some education trust fund money, and we've done a couple of other things to get us closer to that $23 million. Obviously, that's going to be one of the biggest challenges that we have in the budget because it's an actual deficit that we're covering using carry forward funds and one-time funds.
Thank you for your time. We're out of time.
All right.
Appreciate all you do.
All right. Thank you, sir.
Mr. Holford? Medicaid? And since we've done this to everybody else, let's get the graphic up showing the, there we go.
Now, I can yield her some of my time if you'd like for me to.
Now, this up and down thing is explained almost completely by federal action and FMAP changes. And also the way that Medicaid has been handling some of their funds and under budgeting at periods of time. I think all that's accurate. Did I say anything incorrectly there? No? So that's kind of where the pits and valleys are there.
So similar issue with the CHIP situation.
Exactly.
You went through a period of time where you had increased FMAP, increased federal funds, so you didn't have to put as much state money up. The FMAP changed, and so the increase went back up. It was state funds. Yeah, this year, and what the governor's recommended is level funding, like she has for most of the agencies you've heard from today.
So in essence, we're covering fewer people than we were, but it's costing us more.
Sure, yes, sir.
Is that a fair statement?
It's a fair statement, but as Commissioner Azar pointed out back when she would do these, I think a peak at COVID was around 1.3 million, somewhere around there. We're now at about 1,059,000. The population that came off in the unwinding.
And that's about the same number you mentioned.
Very close.
It's close to what we were
Yes, sir.
before COVID in 18, I think 19.
That's right, very close. But that was a low utilizing population when it came off. So that's why the cost.
Now they're high utilizing and the FMAP has changed.
FMAP has gone back down to our normal FMAP. That's correct, and it's back to our normal population that's on there. So,
give him a minute to swap
okay.
CDs or floppy disk, whichever one technology's got. There we are.
So I'm very similar to what Commissioner Boswell said. I'm going to put the budget stuff towards the end since it is a level fund and the appropriation bill is there. Now you will see through this several slides that you're familiar with. We've updated them based on the information that we have, but we do feel it's important that you see these slides over and over because it shows where we are, who our population is, and we also publish these on our website, and so it's good the public has them as well. Just to kind of brief you on where we are right now, at Medicaid, we continue to navigate uncertainty.
And Bo, let me, we started, got you, you're going to be cut short a little, so you got about 22 minutes to get this done.
I'm going to get through it. Yes, sir. Right. I will get through it. I will get through it. So I do want to remind you before I get into my slides, we do not pay medical services. That's a reminder I want to do every time that I speak. We pay for that providers provide the medical services. We pay the bill. Medicaid has a huge impact on the state of Alabama. As I told you a while ago, we're at 1,051,920 Alabamians. We cover 50% of the births in the state, over 50% of the children in the state. And coincidentally, our rolls are made up of over 50% children. At one point during the year, 25% of the population is eligible for Medicaid. It's not lost on me. As we've said in years past, it's not lost on me the job that you guys have and the governor has funding us and the other vital programs. But the $10 billion expended into the economy is crucial to the infrastructure of the Alabama healthcare system. before I get into some of the more familiar slides, I just want to talk to you guys a little bit about what's happening nationally and how that actually relates to Alabama. Briefly, I will just hit on OBA, the One Big Beautiful Bill. Alabama is situated a little differently than what you're hearing nationally about other states. Because we are not a managed care state and because we are not an expansion state, we are not dealt the funding issues that other states are being dealt. There are some things that we will have to deal with in Alabama. Those, I've listed some of them up on the screen, but a lot of them we already do. So it's just going to be either an adjustment to what we already do, or if there is something new, we will get it implemented. You can see by January 1, 27, we've got to have a process to regularly obtain address information for enrollees. We do that already. Enrollees have to report new changes of income to us, new changes of address to us, and we also, during our reviews, we gather that new information. We will do death master file matches. We already do death matches, so we will just adjust it to make sure that we are in compliance with OBA. And then a big one for us is the 2 months of retroactive coverage, because we've always provided 3, so now we're only going to go back to 2. January 1st of 28, we are going to begin reviewing death master file for deceased providers so that we can remove them from the roll as well. And then October 1, 29, you see CMS established verification system. We already do a PARIS matching system. PARIS is the Public Assistance Reporting Information System. We already do that. So what we will do is we will now do it with the established CMS system. And then also in 29, the CMS PERM audit allowances will be reduced.
Since Commissioner, since we're talking about the audits, and don't say anything you don't feel like you can say publicly, but I know I've been kind of outspoken about a third-party review of Medicaid, and I've kind of backed off that now after meeting with y'all 2 or 3 times. And also, can you speak to the new kind of predictive AI software that we talked about? Maybe could you help us find fraud?
Yes, sir, absolutely. So as I told you when we met, and I've said in other areas as well, we have a very robust information technology system at Alabama Medicaid. It's obviously got to be very big because we are servicing 1,059,000 people. But we have developed a system using the appropriations that you guys have already given us to be able to look for anomalies in the system, high utilization, something that where we see billing shouldn't be billed the way it is. It's something that we've always done, but we've had to do it with our workers, our humans actually looking in, trying to find it. They see something, they go through the files, they see the anomaly, and then we start working it. We've developed a system where once the way it's evolving, we're going to be able to immediately notice those anomalies and then quickly get them to our program integrity unit. And when we can get them to our program integrity unit, that's where we have an in-house team of investigators. They travel the state as needed to try to prevent fraud, waste, and abuse. That's not all they do. Our program integrity unit also has provider review units. They check, make sure beneficiary compliance is in check. But that AI tool is going to be able to get us to that point immediately without any kind of lag. And we're really excited about it. It's something we are currently implementing. So I'll be excited to be able to show you all the results of that. But it is important to note, it identifies where the anomalies, where there could be a concern. And I will say, just because there's an anomaly doesn't mean there's a concern. Or just because there's a high utilization doesn't mean it's a problem. But it does allow us to notify or to notice those and get it to the auditors, our internal auditors, quickly so that they can jump on it and act accordingly.
Good deal. Thank you.
Yes, sir. And I will show you this. Chairman Reynolds, your question kind of took care of a lot of it, but I just want you guys to see this is what our Program Integrity Division, these are several of the units that they do have, and that works every day to try to help us prevent fraud, waste, and abuse. And just as a side note, I've only been in this role for 6 months, but I've been with the agency for 16 years. And from day one, fraud, waste, and abuse has always been important. It is very important to us that the folks that need to be on this program are on this program. And it's very important to us that people that are not eligible for this program are not on this program. Likewise, for providers, it's very important that the providers are following our rules, following our regulations, and we're making the payments appropriately. So that's been in place since I've been here. We've had a robust program integrity unit since I've been here. for the entire 16 years. I can't speak to before that, but I'm assuming it was the same way before that. So I just wanted to make that comment as well. But the most important thing is we get out in front. We want to try to stop the fraud, waste, and abuse before it happens. That's what we want to do. So transitioning to the folks that we serve, the Alabamians that we serve, these are going to be slides that you are familiar with. So if you'll take a look right here, and it's important to remember, not only do individuals have to meet income limits and sometimes income and resource limits to be on Alabama Medicaid, they've got to fall into one of these 4 categories. So the first category is our disabled and blind population. You've heard it said plenty, I'm sure. Alabama Medicaid, for the most part, covers age, blind, disabled, children, and pregnant women. There's a few other areas I will talk about, but that makes up the bulk of our population. So this disabled and blind population amounts to 47% of our expenditures, but only 20% of our members. A lot of these, we are what's called a 1634 state, so when they go through their SSI eligibility, they automatically come over to Medicaid. The second population you see here is children. Children are 50% of our enrollment, over 50% of our enrollment, and amounts to 25% of our expenditures. And it's very important to know right here, and I know you have heard us say this before, just because children are on the program does not mean their parents are on the program. Parental income is used for the children to get on the program, but that does not mean that the parents are on the program. The other column over here is aged 65 and over. 9% of our members, 16% of our expenditures. Almost this entire population is what we refer to as dual eligibles because they have Medicare as well, and so Medicare does pick up part of that bill. And even with that, you can see what the expenditure is per member per month. The other category that we have over here is the one that I was talking about that kind of catches everything else, but is only 20% of our population, and that is our other categories, and that is other adults, including pregnant women, parent caretakers, and Plan First members. Now, our parent caretaker group that you see here is the only group that has some parents that could be covered alongside their kids. That is an extremely low income limit, but you have to have somebody in the house that is a close relative of yours under the age of 19 before you even qualify. Plan First, for example, Plan First is a family planning waiver that we have. That is family planning services only is all that is. I do know that nationally you'll hear Medicaid rolls may be a little different, but for Alabama purposes, yes, sir.
Oh, we got a question, and questions always proceed.
Thank you. Sorry to interrupt you.
No, that's fine.
Back to the Plan First.
Sure, yes, sir.
I've talked about this several times, and some of the rules that are hidden behind to say, well, that's federal, we can't do anything about it. But in the Plan First program, like the delayed waiting period to, say, have a tubal ligation, you know, I'm just giving you the background of my years in practice.
Sure, yes,
If you
sir.
have private insurance and you come to my office and want a tubal ligation, we can schedule it tomorrow. If you have Plan First, you have to sign a permit today and wait 30 days to schedule it. I can't. Is that rule still in place?
Yes, that is federal.
Is that federally mandated still, or you?
Yes, sir, it's federal.
I mean, those are just some of the inefficiencies that are in the system. I can't tell you how many times either they didn't show up in 30 days or they were pregnant when they showed back up in 30 days.
I understand what you're saying, but it is still there, and I've confirmed it is federal, and it's one of those things. It's one of those things that we have.
I mean, are there efforts in the Medicaid program to fix those kind of things?
On the federal level,
I mean, are the states saying this doesn't work? I mean, this is a problem.
Personally, I have not done that. I'm happy to talk with you offline just to get a little bit more information on it. I'm obviously familiar with the program and having those type of procedures and the things we go through.
but I'll be glad to talk with you offline and just kind of get some
I'll be
comments.
glad to talk to you after. There's several other examples I could give you.
Yes, sir.
So
Absolutely.
I won't slow you down.
Representative
Thank you.
Yes, sir.
Thank you, Mr. Chairman. Could you address it says here 50% of Alabama's children are on Medicaid. Does it overlap with CHIPS? Or can you explain if that has any kind of overlap?
So there is a Medicaid CHIP population, but as far as CHIP and all kids, it does not overlap. That's a separate, that is a separate population. There is a small Medicaid CHIP population, but as far as all kids, if that's what you're asking,
Okay, so
that's
this number doesn't include that. Okay, thank you.
Yeah, that's kind of what Dr. Harris mentioned earlier. You know, when we took off 300,000 people in Alabama off Medicaid, our CHIP costs went up. I think about $19 million.
That's right. That's right. It is very possible that a lot of the children, we had a maintenance of effort, as you all are familiar with. We had a maintenance of effort, and when that was unwinding, a lot of people would have rolled over to all kids. That's correct. Okay. So along those lines as well, this is a map. You saw this last year. We've updated it, obviously. This is fiscal year 2024. This is the population that's annually eligible for Medicaid by county. So I think this is a very important slide because it shows all four corners of the state and how the Medicaid population is dispersed. What you'll see, there's 4 counties that are below 20%. Of those, all are over 15. But I will point out, fiscal year 24 was still COVID, so we still had some COVID enrollees from the maintenance of effort that are on there. So there may be 1% or 2% different once we get to fiscal year 25, but that would be the same reason as Medicaid pointed out in the budget hearings last year. But what this means is at some point during the year, in most counties, 20% or more of the population are on Medicaid. And if you look closely at the map, it's really more along the lines of 25 to 30% at some point are on Medicaid, and in some counties, 50% of the population are eligible. Again, just pointing out all 4 corners how dispersed the population is. Another slide that we show you each year, or at least I know we showed you last year, based on the monthly average of fiscal year 25, is our demographics pie charts, based on Medicaid eligibles by race and then by gender. What I will point out is the gender, obviously their female is going to be a little bit higher because of we cover pregnant women, because our Plan First waiver tends to be more female than male as well. So you're going to see those numbers. We also have the 12-month maternity postpartum for women as well. So, as I stated at the very beginning, we do not provide the medical services. We pay for the medical services. So to maintain access for these, we have to rely on our provider community. We have a great working relationship with our provider community, the stakeholders, the associations, and they are the ones that provide the services to the Medicaid recipients. And as you'll see right here, this is our fiscal year 25 Medicaid enrolled providers. We have almost 36,000 unduplicated providers throughout the state. I think this is a good illustration of that participation. And finally, we'll get to the budget. Obviously, to serve our members and do everything we do adequately and effectively, it costs money. And the Medicaid team, I can tell you, works tirelessly to be good stewards of taxpayer dollars. I was taught by my mentor that that's what it is. It's not a general fund appropriation. It's not your budget. It's taxpayer dollars, and that's how we look at it. And we do our best to be good stewards of the taxpayer dollars. And doing that, we have to make sure we maintain access to care and weigh appropriate concerns while making sure that we have sustainability and successful outcomes. So this slide we've shown you every year, I think, that I can remember, and this is our Medicaid expenditures from fiscal year 25. What you'll see is that the total expenditures were $9.365 billion. So you can see in the chart, you've got your hospitals, your nursing home, pharmacy, physicians, mental health, the alternative care, health and support, which is kind of, if you'll recall, you passed the ambulance legislation. That's where that would be, our hospice services, some of our waiver services. And then our other is ACHNs, ICNs, family planning, things like that. What I also want to point out is the admin cost is the piece right there is 4%, but only 1% of the entire Medicaid budget is for salaries and benefits. We have 637 employees at the agency. We currently have 137 vacancies. We have 11 district offices spread out throughout the state with Medicaid workers that process eligibility applications. We have a presence in every county, either with a permanent worker in an office or a worker that covers multiple counties. And these employees, they're hardworking employees. They care about what they do. They care about the people that they serve. And I just think it's important to point out the admin cost for the salaries and benefits of employees. In conjunction with this, where the money comes from. So the $9.365 billion, you'll see 72% of that is federal money. 28% of that for fiscal year 25 was state funds. That is reflective of our FMAP. Yes, sir. Okay, yes, sir. That is reflective of our FMAP. Just to give you some examples, obviously general fund, but the other state share sources are things like our sister agencies, maybe the tobacco money, private assessments, and intergovernmental transfers and things like that. Basically what you're seeing is for every dollar, over $2 is put in by the federal government. So again, vital as that money is injected into the healthcare system for the state. And here's our funding need. You've seen the appropriation, the general fund request, level fund of $179 billion, with the agency this year having a $94 million carry forward. And to give you kind of a picture of how we got to that point and how we were able to have that carry forward, when the fiscal year 25 budget was created and proposed, we were in the middle of the public health emergency. We had to make a budget that was predicting what fiscal year 25, which would be outside the public health emergency, would look like and what our utilization would be. Our team did a great job of doing that projection, and then when we couple that with some fortunate outcomes that happened in the program, we were able to get to this $94 million carry forward, which, as I said in August, and as Commissioner Azar always said, we're always bringing back. We're always going to bring the money back.
If I may jump in, I appreciate your handling the funds to a point that you have this carry forward. I also appreciate you showing this clearly to the body about the carry forward and how you're planning on using it and how it affects our appropriations. I think you did the best job of any other agency in outlining that. Thank you.
Yes, sir. And to kind of go into that, it's very important to point out the need, because that's what needs to be focused on. That is the need to run our program. The $94 million carry forward is good. It's great. We're always going to bring you carry forward. We always have. If we have it, we're going to bring it, and we're going to reduce our ask by that. But the 1.273 is the need to run the program as is. That's the need to run the program without any unknown legislation or regulation that could increase the cost. That's the need to run the program without any drug costs that may be coming down that the FDA may approve or put in the Medicaid space. Sure. So it's important to know that and to.
We got a question over
Absolutely. Here. Yes, sir.
I agree that this is good information. The concern that I have is, what is your projected carry forward at the end of 27? Because that's what gets us in a mess, is if we're not looking at that and then that 94 is not there and we've got to go from a 1.273 to a much higher. So what do you project that 94 to be the following year?
Okay, so that's a very good question. To give you a little insight, or the 1.273 for fiscal year 27's need is about 3% higher than the fiscal year 26 need that we're currently working under.
Okay.
So that is a flattened curve a little bit. I'm going to caution you, though, as I say that, because it's based off of fiscal year 25's outcomes. Fiscal year 25, like I said, we projected it in the middle of COVID. So is it an anomaly? Is it the new norm? We just don't know. We're only in the beginning of the second quarter of 26. Once we get halfway through, I will be able to kind of look and see a projection for 26, which will start to give me a little bit better idea of what it would look like when we come to 28. But again, the biggest thing, and I know you heard Commissioner Azar say this when she would do these presentations, healthcare inflation, the unknowns of what could come down is the toughest part of doing what we do. This is a great team. They've been doing this for a long time, and I don't think they would disagree with me when I tell you the toughest part of this job is budgeting and trying to project the unknowns that are out there.
If I may, I would simply observe that you're talking about an amount that is almost close to what the inflation rate is. Now, I don't know if that's a direct correlation, probably isn't, but maybe it's an anomaly, but at least that's semi-good news.
I would agree with the statement, it's good news. I don't know if it's the new norm or an anomaly. Historically, our need has gone up a little higher. There are some things that happened, like I said, in fiscal year 25 that we can identify that made it a little more fortuitous for us. I do not know what that will look like. But like I said, as I get through the second quarter of fiscal year 26, I can look and start to project the trend that we're on heading into the new budget year. That's right. Yes, sir. So, but overall, I will say this is a well thought out budget by the team. It took a lot of work. I do think it accomplishes the mission of the agency and will allow us, aside from the unforeseen things coming in, will allow us to carry out the mission of the agency. So.
Thank you. I appreciate you, Mr. Commissioner. Thank you, the body, for being here. We'll stand adjourned and get to our other duties. Thank you.
Good job.